A very good evening to everyone. Myself, Deepti Paliwal, and on behalf of Female Pelvic Pain Association, FEPPA, and Swati Spentose Private Limited, I would like to welcome all the delegates and the respected faculty to the inaugural virtual workshop of FEPPA on theme Connecting Bladder to Pelvic Health in association with Gwalior Obs and Gynae Society. With this, I take this pleasure to introduce Dr. Urmila Tripathi, who is the President-elect, Gwalior Obs and Gynae Society. She is an Associate Professor, Obs and Gynae, Gajra Raja Medical College, Gwalior. She is an Executive Committee member of GOGS. She is an Executive member of FEPPA, and she is the very first member of a FEPPA to take this awareness initiative in form of a today's workshop. So I request Dr. Urmila to please come on the stage and take the charge of this entire session. Over to you, ma'am.
Thank you, Deepti. Thank you. Actually, there are two kind words for me. Welcome, everybody. And let me introduce Dr. Veera, who is President, Gwalior Obstetric Gynaecological Society in the current session. And she's Senior Consultant at Janak Hospital and Secretary, Madhya Pradesh Obstetric Gynaecological Society, Vice President of IMA in 2018, and she has chaired many sessions in AICOG. Welcome, Dr. Veera. And since you are the President of Gwalior Society, you represent us to welcome and give an introductory speech for this webinar.
Thank you, Dr. Urmil, for kind words. And I welcome everyone.
Please unmute. Unmute yourself.
Okay, can you hear me now? Hello?
Yes, very
okay. Oh, good evening, everyone. I welcome everyone for this webinar. Today we are going to have inaugural workshop of FEPPA, that is female pelvic pain. I want to tell everyone, those who are not aware of what is FEPPA, that is Female Pelvic Pain Association, and in association with GIPS, that is another a global IC and BPS society. So we are indeed very elated and happy to host the first inaugural workshop. Thank you so much. Thanks to Dr. Anita, Dr. Vidya, they are the co-founder, and the also core member is Dr. Urmil. So they all planned it and organized it, the very first meeting here. So thank you so much for giving us this opportunity. Bladder pain syndrome is commonly mistaken as a urinary tract infection, UTI, and often difficult to treat because antibiotics cannot, sometimes have not shown very good results in them. And even with the potassium chloride, I was reading through that said the potassium chloride solution, the pain is enhanced and then with the water. This sometimes then doctor diagnoses it as then BPS. So, and this becomes chronic and can also lead to depression in females. So it's such a pertinent problem of today. Before that, we were just ignoring it as a UTI. So let's hear from our eminent speakers and Dr. Amita, Dr. Vidya, Dr. Ajay Rane, who is from Australia. We are all waiting to hear him also, Dr. Navita, connecting bladder to pelvic health. Before that, I think our patron would like to say something. I welcome everyone again, and now I leave the stage to you. Urmil. Hello. Urmil, over to you.
Okay. Yes, thank you, Dr. Veera. And I welcome our secretary, Dr. Shashi Bala Bhosle. A big hand to her. Hello, Shashi. Okay, she might be joining very soon. And she is at the moment honorary secretary of Gwalior Obstetric Gynaecological Society. And she's a specialist in the Department of Public Health and Family Welfare. We'll be seeing her again at the end of the session. Next, I welcome, yes, namaste, Mr. Vishal Jajodia, who is the Managing Director of... Swati Spentose Private Limited. And good evening, sir.
Good evening.
I would like you to address our session and tell us about this FEPPA motive. What is the motive behind it?
Yes.
Okay.
Thank you. Thank you very much. First of all, I would wish all the super women a happy Navratri. Today is the 8th day, Ashtami. We did the Ashtami Puja. And another special thing is that in our company, we are a 50-year-old company. And as Swati Spentose is actually, Swati is my wife's name. And we built this very big company, but she has made it successful. And she has got a team of 10 women in my company like Dipti, who have driven the whole company to where we are today. We have been able to make our company a global benchmark in bladder pain. And so, sometimes I used to wonder or worry as an entrepreneur, as a leader, that I've got so many women in my company and I'm very responsible for them. And it was quite a challenge and a matter of stress for me sometimes. But then I realized that this is my journey, this is my destination. I'm blessed to have the support of these 10 women who've made my company successful. And while dealing with women at our home, also we see that women go through a lot of challenges. And in spite of all the education, my wife still gives the last priority to herself. And this is a consistent challenge. And I've attended some conferences in Middle East and in Europe. And I have seen globally, the situation is worse than India. In countries like UAE and Egypt, Turkey, I have seen there's a huge gap when it comes to dealing with pelvic pain as a subject. And then I met, and then Dr. Amita, we set up this GIBS, and Dr. Sanjay Pandey, Dr. Rajesh Taneja gave us the initiative, the push, and the shape to this association and this work for last 5 years. And that's where I met Dr. Amita, Dr. Vidya, Dr. Navita, and Dr. Ranjana, and Dr. Urmila, who are part of this beginning. And Dr. Amita had been constantly mentioning that, we need to do something in area of pelvic pain because everybody is, many of them are busy with obs and gyn issues. But pelvic pain as a focus subject is really a big gap in our country. And I'm sure men cannot experience the suffering women face, but everybody has had someday or the other a mild urinary pain. And we hear stories of people really suffering for long. And this is one reason why, I said that we must, and I was very blessed that I got Dr. Amita constantly putting a red flag on this need. And hence, a big thank you to Dr. Amita, Dr. Vidya, and Dr. Navita has been a great support to us. She had been a great support when my mother-in-law was suffering with pain. And the way she was able to guide us, I think many times we cannot solve all the problems, but how we deal with the situation, how we guide them, how we create awareness, I think sometimes that is 60 to 70% of the resolution. And I still have a video recording on my company website where Dr. Urmila was speaking about the first time she attended GIBS. And she said that, I was taking the flight to Mumbai and I decided to take a class on pelvic pain for her students. And that message always resonated in my mind that Dr. Urmila is also one of our very special partners. And it is just a coincidence today that the first inaugural session we are having with her. So a big thank you to Dr. Veera Lohia, Dr. Bhonsle from GOGS, Dr. Urmila for hosting us in the beautiful city of Gwalior. Dr. Ajay Rane, thank you very much for being the international speaker. We are very excited to learn from you what perspectives you bring to us. And as our continuous board members, Dr. Amita, Dr. Vidya, Dr. Navita, Dr. Ranjana, really a deep gratitude for supporting this initiative. I would like to mention we are a 50-year-old pharmaceutical company. And when I tell you this, you will not believe me, but making money doesn't excite me. because after a certain point, every extra money which you make is just another, and the lockdown has showed the whole world that you don't need money to have a beautiful life. Even you're with your family and eating 2 square meals a day at home, it's good enough. So what really excites me is making a difference. And with bladder pain, we have made a global impact with GIBS, that today when we deal with customers, we get a respect of another league. So just yesterday, Endo Pharmaceuticals from America sent us a message that we want to work with your company on Pentosan. And if we are not working with you, we will drop the project. Mylan, Teva Pharma, Endo Pharma, all are these companies, they contact us, and when they say these words, I think it's the greatest earning one can achieve. So with this, I won't hold you all long. I'd like to thank all the doctors for the support, and I personally commit to you that you will see this journey open new platforms for the suffering patients. And all of you, I will share my email ID. Anything scientific, you can count on me. I will be most happy to collaborate with the doctors in doing any scientific pursuits which can make a difference in the world in area of pelvic pain. So thank you very much, and over to you, Dr. Urmila. And once again, thank you everybody for the support.
Thank you, Mr. Vishal. It is too much for me to take. Thank you so much. And I would like to add that he'll be taking up the diabetic nephropathy and its management very soon. And more than that, he has mentioned to me, he is taking initiative for gut. You understand, for like, they are not medicines on nutrition and prebiotics, probiotics. I mean, that way of improving our health by getting the gut flora tested and the corresponding, isn't it, Mr. Vishal?
Yeah, it's if you allow me, I'd like to add some interesting information on this.
I wanted that. Yes, please do.
So, I attended a conference at Cambridge on human microbiome. There were about 200 scientists from all over the world. And one of the American scientists who had worked 10 years on the gut flora, he openly made a statement that after working on gut flora for 10 years, I have put all my work in the dustbin. Because he said, I was so scared to learn what I learned, that the gut flora is such a complex subject that the more you know, the more you get confused. But we are also working with a group of British scientists who I have read a lot of documents, and I will share with all of you all little by little, that 70% of the hormones are made in the gut. And so when we come to women, I think a lot of hormonal issues which presently are being dealt with medicines, I would be very keen to first understand the subject and bring the subject to you all, where we can work on improving the women hormone via nutrition and certain non-medicinal solutions, leading to improvement in the hormonal changes. So we've got a lot of experts from UK who are collaborating with me for last 5 years. We are coming up with some new diagnostic kits for the gut. There are 200 specimens which are documented. We are having a vaginal microbiome test, oral microbiome test. These all we are going to bring forward. But the reason why I've not brought it forward, because I've still not got a complete answer that when we do the diagnostics and the patients get the report, the next question the patient is going to ask, what should I do? Now, till we don't have a good answer, opening a Pandora's box is not a solution. But I will keep you all updated on this gut. We are surely going to have some interesting intersections with women health on gut, because it's a lot to do with hormones. So thank you, Dr. Urmila, once again, to allow me to share this.
No, I'm very glad. I wanted this because I was very impressed. I wanted all my panelists and the delegates to be introduced to this new topic. Yes. Okay, thank you, Mr. Vishal.
Thank you once again. Yeah.
Now we begin with the first session of our webinar, and I'll be introducing the chairpersons to it. The first and foremost is Dr. Amita Jain. Amita Jain deserves a big applaud, and everybody's taking my name, but I would take her name. It is her strong initiative which set the train going. Okay, So Dr. Amita is the founder member of FEPPA and executive committee member of GIBS. And she's a senior consultant urogynecologist at Medanta, the Medicity, Gurgaon. Welcome, Dr. Amita. Dr. Kusum Lata Singhal. She's a consultant gynecologist and laparoscopic surgeon at Koteshwar Hospital, Gwalior. And she has been the president of Gwalior Obstetric Gynaec Society and a very vibrant gynecologist. Dr. Roza, our chairperson, she is MS FICOG and director and consultant at Olyai Hospital, and she has interest in reproductive endocrinology, infertility, and high-risk pregnancy. And I would like to share that she has been the vice president of FOXY from our West Zone, and she leads the flag. Welcome, Dr. Roza, and I hand over the mic, carrying forward of the session to you.
So I think without wasting time, I would just like to pay a special thanks to Dr. Ajay Rane for accepting my invitation at such a short notice. And please display his. So that's the thing, that whatever I am today is because of him. He actually showed me the first step of urogynecology field, and still I am following him. I am asking anything I require in my any kind of decision making. So welcome, Dr. Ajay Rane, and I hand over this responsibility of introducing him to Dr. Roza, because she told me that even she got a chance to do a fellowship under him. So Dr. Roza, next you please.
Thank you so much, Amita, for your good introduction. And I would like to congratulate Dr. Urmila Tripathi, who has been really, after it to bring Professor Rane to Gwalior for the first time. Well, talking about Professor Rane, I mean, words cannot just explain everything what he is. As an academician, he's been the director of he is a director of the Urogynecological in Townsville Hospital. And I had the opportunity of really being with him and seeing him operate on cases which have been spoiled by his senior resident, if you remember that day, and you came in without putting him down. You took over the case and you handled it so beautifully with a vaginal vault. He's been awarded over a number of awards, and of course, the best surgeon, best Euro chair for FIGO Fistula Committee. He is the professor and head of the Department of James Cook University. And he has been the finalist Australian of the Year 2012. I mean, isn't it a pride for India to have someone there to be the pride of Australia? It's not easy for anyone to come to that stage of life. He's been awarded the Mahatma Gandhi Prithvi Award 2016, awarded a Pride of Australia 2019. Professor Rane, congratulations. Well, he has also been, besides academic, a filmmaker of Riwayat Against Female Infanticide, which shows about his human touch and the wonderful heart that he has, a heart of gold, for people serving women at any place. He's been to a lot of societies outside in the third world countries helping with this organization. He's been the innovator of the Perigi Menhir Dunes. It's something that is to do with, the pelvic position when we sit on the Western toilet, and I've been able to see this closely associated with him. He's been a philanthropy with Dignity Sanitation India, Flourishing Women in Pacific. Academically, he's been writing a couple of books and a lot of peer-reviewed papers in index journals. He's been blessed with his beautiful wife and 2 children. And I think, being a wonderful human being, Professor Rane, you've been progressing so well, making India really proud of you. Having a heart of gold, you've been serving the women. And I think after hearing your talk, all of us will leave our infertility practice and obstetrics and start doing urogynecology. I think that's absolutely. I think more than that, all of us will agree once we hear him. It's such a pleasure to have you in Gwalior. Thank you so much for taking time out of your very busy schedule. I know you've been in an emergency but you look so always happy and bright, and the background that you have, it shows how lively you are as a person. And the stage is yours now.
Thank you. Thank you very much. Thank you. Thank you, Roza. Thank you, Amita. I'd like to thank Vishal for being the second male in the group, it makes me just feel a bit more sort of secure. Of course, Urmila, thank you for your kind invitation. And, I feel completely out of place here because stress incontinence is not necessarily something FEPPA should be interested in, but I am really interested in what Vishal had to say. So I'm going to make a couple of comments on that. So we are probably doing one of the world's largest fecal microbiome study in women with chronic undiagnosed pelvic pain. And we've just been awarded an NHMRC grant for that for about $3 million. And it's actually a trial that's being run by a medical student. Actually, maybe Amita may have met her even as well. So yes, it's a very interesting concept, the gut microbiome. There is a guy in Seattle, Mr. Jain, J-A-I-N, Vishal, if you're taking notes, stay away from him because he also has a microbiome testing kit. And I think it has become more of a fad than a science. And I don't even believe very strongly that the British have got it all sorted. We all believe very sincerely, and that's one of the reasons why you may not invite me again, but that's okay. I just think that you need to be very careful when you offer people diagnostics that mean absolutely nothing to them. The third important part about the microbiome, which we are currently interested in, is the aging process. And what you really want to look at in India is telomeres and telomerase, and how by manipulating the gut microbiome can you actually control telomerase production in one's body to protect your telomeres, which allows you to slow down aging. You can see the classic example. I'm 85 years old, but I look pretty young, right? Yeah, so that's the next step. The last part is Camille, who is a Lebanese person. I thought he was the CEO of Endo Pharmaceuticals. Maybe he has changed, but I had a lot of dealings with Camille. Maybe we can talk privately sometime about Camille because he's a chameleon. So I think you need to be very careful about Endo Pharmaceuticals as well. I've worked with them before. I just heard all these buzzwords and I thought I should put my 2 bits worth in. And I'm not even a consultant for your company, so I'm not going to charge you. This is all free advice I'm giving you, Vishal. It is an amazing market. So the next part is
sorry, I'll just take one comment. I'm sorry for regarding all the pharma companies. Trust me, I'm a completely non-pharma guy because I believe
I got that.
Pharma is for people who don't want to work on their health. But the most important thing with regard to the microbiome testing kits, I completely agree with you. I'm not very clear what is the solution they are bringing on the table. They are giving.
That's why we should talk.
So that's why I've not launched it, although I've worked on it 3 years before. So yes, we'll be in touch, and I hope
I think that'll be good.
Some useful knowledge.
Before we start with the case discussion, which is going to be 15 minutes, there is a very interesting concept that you have brought out here. So for example, if Ajay Rane commits a crime or he rapes a woman, the identification of him is done through something called your DNA, right? So your DNA is very specific to you. They will take my saliva, they will test the patient, the victim, they will find my DNA, they will cross-match it to my sample, and they will say, you were in this place at that time, you raped this person. Your identity with your DNA is absolutely unique unless you have an identical twin, right? Now, to be you in your body, to be Vishal, you have 2 billion DNA base pairs that tell you that you are Vishal. 2 billion DNA base pairs. But your entire body contains 10 billion DNA base pairs. So where do the other 8 billion DNA base pairs come from?
Microbes.
They come from your gut biome.
Microbes.
So the question really is, are they the owner of the body, or are you the owner of the body? In fact, they have more DNA base pairs and they're just driving you like a drone. And that's why the microbiome is so fascinating, because the microbiome is now considered the owner of the body. And it manifests in Parkinson's, in whatever diseases, diabetes, whatever you want to call it, because the biome is what overpopulates the individual. And therefore, we find the gut biome an extremely interesting phenomenon. Now, there is a urinary microbiome, there is a vaginal microbiome, there is a gut microbiome, but your 7.6 billion base pairs are actually in the gut microbiome. So the vaginal microbiome and the urinary microbiome don't make such a difference, but the gut microbiome is. So Amita, do you want me to start sharing my screen for the lecture? Is that what you want me to do?
Yes, sir.
I think yes.
Okay, I'm on. Let's hope. So this is going to be a very short lecture. I think you guys have probably heard me on very many different occasions. Amita wanted me to talk a little bit about what would be the best way to address a case of stress urinary incontinence. This is my bread and butter. So again, thank you once more for your invitation. I'm just going to be as brief as I can. And let's start by saying that involuntary loss of urine on effort or physical exertion like sneezing, coughing, jumping. So all these efforts are sudden efforts. I think you have to decipher the difference between sudden effort and chronic effort. The sudden effort is like cough, sneeze, laugh, jump, run. Chronic effort is like straining. So this is not leakage of urine on straining. This is leakage of urine on sudden effort. And this will be very important for you to understand as we move along the next part. So the important part to understand is the urethra basically perforates the pelvic diaphragm or the urogenital diaphragm. And right at the end, near the bladder neck, you have the levator ani muscles. And these are the pubococcygeus and the puborectalis. So puborectalis is part of pubococcygeus. These two muscles are the only muscles that you can contract when you do your pelvic floor exercises. They say Kegel exercises. I think it was a Punjabi name because it was all about Kegel, right? And iliococcygeus is a stabilizing muscle of the pelvis. If you were to be able to contract your iliococcygeus, your pelvis would move like the wings of a butterfly. It doesn't, it's a stabilizing muscle. So the iliococcygeus does nothing to support the urethra. The perineal body is very important because it also forms the keystone on which the entire building of the pelvic floor support right up to the cervix occurs. So it's very important to have an intact perineal body, something that is neglected when women give birth and they have either a tear or an episiotomy, and that is not reconstructed very well. But I'm going to ask you my first question. What happens to your levator muscle when you cough as compared to when you do a Valsalva? Two different actions completely. A cough is sudden, Valsalva is a strain, as if you want to try to open your bowels. And I think it is very important for you to understand this is what I do with live lectures. So I'm going to just passively give you the answer. But before I give you the answer, I want to show you that the urethral support mechanisms have got the pubourethral ligament, which is the main support mechanism. But along with it, it has the compressor urethrae, the sphincter urethrovaginalis, and the external urethral sphincter. These are all components of the sort of perineal muscle complex, ischiocavernosus, bulgiospongiosus. They all come around there, have a little bit of donation of muscle fibers around. So the urethra has two supports, a ligamentous support and a muscular support. This is also very important because if you lose the muscular support, it is called intrinsic sphincter deficiency. If you lose the ligamentous support, you get urethral hypermobility. And they are different pathologies altogether. Both patients complain of stress incontinence, but they have two different reasons for stress incontinence. So just to answer your question, when you cough, the levator actually braces. When you do a Valsalva, the levator balloons. Two different actions. So you have an automatic Kegel when you cough, but when you strain, the levator muscle actually balloons. So no point in saying when I strain, I leak urine. That is not stress incontinence. It has to be sudden motion. Good, we'll stay there. I think that the incidence is around 35%. I don't believe the 4% is true. Definitely aging, we're all getting older. Obesity, without any question, and smoking. I have patients who smoke have the worst pelvic floor tissues I have ever seen. All our complications that occur with patients, recurrences, mesh erosions, all occur in smokers. Unfortunately, in my country, women are smoking more than men. So it's a bit sad, and younger women are smoking more. So, our business will continue to grow. Pregnancy itself is a controversial thing. A lot of people say women get stress incontinence because of pregnancy. I don't necessarily agree with it. And definitely, if you have a cesarean section, you have an early protection from stress incontinence, but it's not lifelong. It only lasts about 12 years. While vaginal birth is not only non-protective, it's probably causative if you don't actually support the perineum and the lower third of the vagina during childbirth. But whatever the situation, I think the most important thing to understand is that if you have a patient with stress urinary incontinence, you must take a detailed urinary history, not just about stress incontinence, about stress, urge, mix, frequency, urgency, nocturia, how they void, their poor stream, do they dribble, have they got dysuria, have they got hematuria, do they have to put their fingers in the vagina to empty their bladder? You can get digitation required if you have a pretty significant cystocele. You need to quantify what the stress urinary incontinence leak is. I bet almost every Paris woman has sometimes leaked urine. That doesn't mean that that's a significant stress urinary incontinence. Question is, what is the bother? What is the severity of it? And how does it affect their quality of life? So I think these are very important points before we lead into what's the ideal solution for treatment of stress incontinence. Nothing changes in life, Roza. Nothing changes. You still have to do genital inspection, genital examination, a cough test, some form of quantification of prolapse if you see it. Nothing changes in life. What you learned as a medical student, you gotta still do it. You cannot substitute clinical examination by investigation. You cannot substitute it. You have to examine the patient. It's very important. And so again, I usually ask, what do you see at genital inspection? What do you see at genital? All the answers are here. So on genital inspection, you want to see atrophy, excoriation, but excoriation, very common if women use pads all the time. It's a very sad thing. They're very irritated by it. genital examination, always do genital examination at Valsalva first and then cough. First ask the woman to strain to look for hypermobility or bulge, and then cough to look for a leak. If you want to do a cough leak test, put 200 mils of water in the bladder, or make sure that the woman doesn't have more than 200 mils in her bladder if you ask her to come with a comfortably full bladder. When you do a prolapse type of assessment, always assess the prolapse at maximum strain. And Amita and I have always had this chat. We only operate on stage 3 and 4 prolapse, which is prolapse that comes out of the hymen on straining, and that is prolapse repair for the patient. Any other prolapse, stage 1, stage 2, is prolapse repair for the doctor's bank balance. It is not for the patient. It's absolutely not necessary. So always make sure that you only operate on stage 3 and stage 4 prolapses. I would say always you do a midstream urine sample, but I don't think a lot of you do something called a bladder diary. I know that people sometimes don't have a lot of education, but explaining a bladder diary is not that difficult. You can actually tell them, kitna aap peete ho, kitne baar jate ho, kitna jate ho. It's not that difficult, but I think it's important. Bladder diary gives you a snapshot, only for 3 days. You just don't have to do a whole week. And then I was talking about intrinsic sphincter and hypermobility, and we're going to answer these 3 questions. Who has it? Who has intrinsic sphincter? Who has hypermobility? How is it diagnosed? And why is it important to diagnose? So these are very important points that we're going to talk about. This is just an example of a bladder diary. It's not very difficult. So there are lots of bladder diaries available in Google. In fact, they're available in 23 different languages. So I think in India, you can choose the language you want and there's a bladder diary. It's not a problem. It does give you a fair idea of what's happening in the woman's life as far as the bladder. If she is drinking 20 cups of tea and 3 bottles of Coca-Cola, forget it. It's not stress incontinence. It's definitely irritative bladder symptoms. And this is where FEPPA can make a big difference, because all these things are bladder irritants. And we are currently in a massive sea of consuming bladder irritants, which lead to bladder pain syndrome, interstitial cystitis, seeing it much more than we used to before. I'm sure Amita would agree with me. So this is just pertaining to stress incontinence. We're not going to go any further. I've got 5 minutes left. Who has intrinsic sphincter deficiency? Older people over the age of 70, previous failed incontinence surgery, maybe radiation or some form of treatment for cancer locally. Unfortunately, the only way to diagnose it is through urodynamics. It's a slightly complex test, but our maximum urethral closure pressure of less than 20 centimeters of water is pathognomonic of intrinsic sphincter deficiency. Why is it important to diagnose ISD? Because you get extremely poor results, 40% success rate with TOT, 40% success rate with colposuspension, and 30% success rate with physiotherapy. So it's very poor results with these patients. डॉक्टर 25,000 रुपए की टेप लगाई, कुछ नहीं हुआ नहीं क्योंकि diagnosis was not correct, right? So I think it's very important for you to understand, not just डॉक्टर को क्या आता है, उसने टेप लगाई लेकिन टेप कहाँ लगाई होगी, गलत जगह लगाई होगी. Not necessarily true. If you have ISD, it's not going to work, right? So hypermobility, who has it? Young, Paris, active women. How is it diagnosed? You can diagnose it by urodynamics. You can diagnose it by transperineal scan. You can diagnose it by simple examination and a cough stress test. Why is it important to diagnose? Very good results with the TOT. 85 to 90%, same with a colposuspension, and a 65% sustained success rate with targeted physiotherapy of the pelvic floor. It has to be targeted, has to be done properly by a proper physio who understands what the pelvic floor is all about. Should you do urodynamics on all patients with stress urinary incontinence? I think what I've tried to explain to you is, fortunately, 70% of women who come with stress incontinence have hypermobility, 30% have ISD. So majority of the patients coming to you will have hypermobility. So you can scan them, you can examine them, you can do a cough stress test, you can do a bladder diary, you can do a quantification test with a pad test. All these aid your diagnosis and management of the stress incontinence. So the short answer is, it's not possible to do urodynamics in all patients with stress urinary incontinence. So, but you have to do all the other things before. Then I can protect you in the consumer court. When you go there and they go, urodynamics nahi kiya, tape lagaya. So then I can help you because you did everything else, which is very important. Good. Like I said, urodynamics is a slightly complex situation. I know Roza was talking about done easy, but we won't do that at the moment. But again, what has happened is I was listening to Vishal, and Vishal, I'm a reverse sort of Westerner. I actually believe that the Indians are giving up all the good things that they have, like the squat toilet, like yoga. So we have to now create, reverse engineer some science so that people who use the Western toilet can get the benefit of the squat toilet without necessarily changing their Western toilet. Washing rather than wiping is now shown to be 65% efficient in preventing recurrent urinary tract infections. This is just new data coming out. We are doing this work where we're using a handheld perineal wash bottle called a bidet bottle. And we're finding that women who are diabetics, especially older women, much easier for them to wash from front to back, prevent recurrent urinary tract infections. This is what science should be all about. Simple interventions for amazing gain in their health. So I'm very proud of those two things. So hold your breath. There will be soon a Rane bidet bottle, which is a squeezing bottle you can take anywhere with you on the airplane, everywhere, and wash yourself instead of wiping yourself. Because we have some data now that shows that 70% of women do not wipe themselves clean. It's the truth. So I think men are the same. You cannot wipe yourself clean. It's not possible with toilet paper. So it's important to understand the value of washing. Anyway, we're moving on to the end of our talk. What are the treatment options? So you can do pelvic floor exercises, 4 months only. Not allowed to do more than 4 months of pelvic floor exercises. If you're no better, you have to move on. You have to go to a doctor because otherwise the women lose hope. It takes them a lot of strength and courage to come forward to say, I've got stress incontinence. And then death by physiotherapy is not a good death. So 4 months. I challenge you all. 4 months only. You can use some of these bladder neck support prostheses. They're not available very freely. And I think it comes in the way of intercourse. You can't wear it all the time. Then you have the 2 slings, the TOT, the obturator, transobturator sling, and the retropubic sling. I kept talking of the 2 slings because I know a lot of people do TOTs. And not a lot of people do retropubic slings. And there's a reason for that. These are more complicated. They're more difficult. It involves passage of very long needles bluntly. And of course, if you're in the UK now, they've stopped using slings. So those of you who are still living in the British Raj, you can follow those people and do nothing for your patients. They're doing perch colpo suspensions. So now you are performing an operation that you haven't done since 1990s, much more complicated operation. And therefore you're getting much, much severe side effects from such operations. And bulking agents, of course, they are palliation in case there is a failure of any of these procedures. So Vivek Joshi is the guy in KEM Hospital in Pune who does a lot of colpo suspensions. He has really good experience with it. And I just believe that if you keep doing them, then you get better at it. But if you stop doing them, which we did, my last scalpel suspension I did was in 1997. Now I'm doing laparoscopic birth scalpel suspensions, which is much easier, but we have had to relearn everything that we do. Now, Amita, I don't know whether do you want me to show you some videos? Because I'm almost done here.
I think, sir, we are actually
very late.
I think, yeah, time is
good. So I'm going to leave you with these conundrums, because I just want to put these questions to you. Mixed stress incontinence, what to treat first? Intrinsic sphincter deficiency, what's the best treatment? Stress incontinence and prolapse, would you do simultaneous surgery or staged surgery? Occult stress incontinence, what does that mean? And would you actually treat occult stress incontinence if you're repairing a prolapse? If you have a failed sling, what do you do next? And if your patient doesn't void, what do you do next? So Amita is going to talk to you about all that. She's got all the trial of void protocols and everything that we've got.
So you left all the questions of the audience.
Thank you so much, Dr.
As the conundrum.
Yeah.
I want to leave you with this very important part. Aging is a state of mind. Death is inevitable. But if you want to age, this was my last year. I have rejuvenated myself. I do bodybuilding now. So I think for someone who's pretty close to 60, that's not bad. I think I give these young girls a run for their money. And I do believe very strongly that aging is a state of mind. And on the 14th of November, I'll be back on stage with my next bodybuilding competition. And I think the important part to understand is that we have to allow the brain to be quiet, calm, and to think clearly. And then I think your body will follow. So I think it's important that we stop stressing. We stress too much. And I work very hard, but I don't stress. This has only happened in the last 10 years. But it's just some little thoughts I want to leave with you. And thank you so much for your wonderful invitation. Amita, it's lovely to catch up with Roza. I'm going to make a confession now that I finished my talk. I actually thought the talk was tomorrow.
Thank you.
But thank God I got your phone and I finished my case in time. And Vishal, it's a great pleasure to meet you. So I'm gonna stop sharing now, guys. And if I don't know whether there's a Q&A, but I'll just mute and stop video and see how it'll go.
Thank you, Dr. Ajay. It was a real pleasure to have you here with us. And so beautifully you have explained the subject, which is really very barely discussed in detail. And yes, I agree. If we do not diagnose the type of incontinence correctly, our results are going to be affected. That is really very much true. Most of the times we are caught because of wrong diagnosis, because we don't pay so much attention. And I am really impressed with your initially you said the microbiology, the flora, and I 100% agree with you. Billions and billions of microbes in the urinary tract and the gut, they are controlling us. And that is really to be known and to be really thought of. And next is the way you said that the age is just the state of mind. That also I 100% agree. So many things in our body from top to bottom are controlled from our mind. So if you are young at your mind, you are young at your body too. And really, you have discussed this thing. You have made aware everybody so nicely, so beautifully. Thank you so much, Dr. Rane. It was a pleasure to have you here. Thank you.
Professor Rane, if I can ask you the availability of Dunes in India, if we would like to know about it.
Yeah, sure. So at this moment in time, what has happened is COVID has happened. And our production was actually based in Hyderabad. We, however, have sold our company to Target USA. So the production is actually going to move to Washington State. But I think we will have a fair amount of supply in India by February 2021. So I think everything is slowly opening up. I know that India has now opened its borders for OCI cardholders. So I'm thinking of jumping on a plane maybe in early next year and meeting all of you. I miss you guys so much. So it's wonderful to do that. But yes, we look at February 2021, just to answer your question. Thank you.
Yeah, that's good. Thank you. Look forward to see you soon.
And I think, Professor Rane, you can answer the question in chat box because we are running short of time. So please answer your questions.
The very questions that.
Thank you. I will stay on the chat and keep going. So yeah, thank you so much. Thank you. I don't want to keep you. You keep going. You're doing a great job.
Thank you, Dr. Rane. And now we begin with our second session, in which I invite the chairpersons. Dr. Yashodhara Gaur, welcome. She is professor in obstetrics gynecologics, and she is the present vice president of MPOGS and vice president of Medical Teachers Association. And she has just been the past president of Gwalior Obstetric and Gynec Society. And we had a vibrant year, colorful year, and academically very rich. So welcome, Dr. Yashodhara. And hello, Dr. Neelam. I introduce you. She is my colleague in GR Medical College as Associate Professor of Obstetrics and Gynecology. Very efficient surgeon and a favorite of the students. Welcome, Dr. Neelam. I request both of you to take over the proceedings.
Good evening.
Good evening.
Hope I am audible, of course.
Yeah.
Good evening. So we heard Dr. Ajay Rane. I am a big fan of him and his execution and his perfection and his control over the subject. Thank you, Dr. Ajay Rane, for being here in this workshop at the GOGS. But my duty here is a different duty. I have to welcome our next speaker of the next session, Overactive Bladder. She will be on Overactive Bladder, current and advances. Overactive bladder is an entity which is found around 1 million cases per year as reflected in literature, which I gone through yesterday only. Overactive bladder is a condition that affects the quality life of our women. And most important thing is that the people doesn't know much about it. They do not talk about it. Women doesn't talk about it. So it's a very good initiative by the FEPPA and Dr. Amita Jain. Sorry. She is speaking on this important topic of, which affects the quality life of our women. And Dr. Amita Jain is MS Obs Gynae and she is Senior Consultant in Urogynecology at Medanta Urology and Robotic Surgery Institute, Medanta, the Med City, Gurugram. She is founder member of FEPPA and General Secretary of South Asian Federation of Urogynecology, and she is very active. It's evident from her CV that she is so much active. She is Executive Committee member of GIPS. She is committee member for National Guidelines on Urinary Incontinence of USI. She is also member of various organizations, various academic and clinical organizations. She is member of writing group for terminology and standardization paper on female bladder pain syndrome in collaboration between IUGA and the American Urogynecological Society. So talking on such an important topic which affects the day-to-day life of our women, who else can be the best person than the Dr. Amita Jain? Dr. Amita, now I invite you. Now stage is yours. There are many questions which my friends and my juniors have asked regarding the overactive bladder. I hope those questions will get a solution or will get a answer, and we'll discuss it after your session is completed. Welcome, Dr. Amita Jain.
Thank you so much. I think you are able to hear me. Hello?
Yes, of course, you are audible.
Yes, yes. So thank you so much, Dr. Yashodhara, for this nice introduction. And I'm very thankful to Dr. Urmila because she told me that we should cover this overactive bladder. And actually, it is a very important differential diagnosis of one of the most important clinical diagnosis of pelvic pain, that is interstitial cystitis. So we must know that how to deal these things together. So I'm going to talk about the current issues and advances. So, Dr. Rane beautifully described that how to differentiate between types of incontinence just on the basis of history and examination, and few preliminary tests like urinalysis. And in few patients, if you are suspecting voiding dysfunction, you need to know the post-void residue as well. Otherwise, just simple diagnosis and you can start the first line treatment. No invasive investigations are required. But I just want to highlight this fact that many of the women who are coming to you are actually not reveal that they are having incontinence. They will come up with something else like repeated fungal infection, recurrent UTI, or many other things. And this is the picture of one of my patients in OPD. So what you have to do, you have to ask, once you are seeing these kinds of complications, leading question, whether they are suffering with incontinence. And then you have to actually decide the management depending on their comorbidities and their age and everything. Now we have learned this, very popular mnemonic since years. And actually it is true today also, because the diaper, this is the thing which we have to rule out to know the aggravating factors which could be present in the history. And actually just looking on these things and treating these things, you can decrease the severity, like delirium or confusion. It's very common in elderly population and they just forget to pee, and because of the overfilling, they have urgency and they leak. So you have to understand and you have to ask for prompt and scheduled voiding that will treat the thing. Infection should be treated, and it has been seen that in postmenopausal ladies, if you are treating atrophic vaginitis, there could be improvement in the symptoms of overactive bladder as well. You should ask any start of new drug which can cause sometimes increased production of urine or decreased control on the urine. So if it can be changed, you should ask for any psychological factor, excessive urine output, even the restricted mobility. I have seen so many patients after getting a knee transplant comes to us because their situation is aggravated of incontinence. That's why they are coming to us. So that's the thing, you have to counsel these patients. And also constipation should always be treated first, because if one organ is taking, pelvis is a very small space. So one organ is taking a lot of space of that part, then probably the other organ like bladder won't be able to work efficiently. So self-management techniques will cover all these things. Fluid management, by this time patient must have filled the bladder diary. You can come to know that if they are drinking excess, this is not good. Even drinking less is also not good. Why? Because it will produce concentrated urine, and which is irritant to the bladder. Also, you should ask them to avoid too much of caffeine in any form. Alcohol, even if they are smoking, it should be stopped. Weight should be reduced, and also constipation should be treated. The importance of time to schedule voiding, I already explained. Now, Dr. Rane explained the pelvic floor muscles and how to use it for the SUI. But even for the urgent continence, pelvic floor contraction actually causes reflex inhibition of the bladder contraction, unwanted bladder contraction. So it has a role in overactive bladder as well. And on first visit, you have to see whether patient is able to recognize those muscles or not. If not, then you can take the help of biofeedback, these vaginal pulse perinometer. Even if this fails, then electrical stimulation. There is no harm in giving a initial trial of 6 weeks for these things before starting any treatment. And even then, if you are going for the pharmacotherapy or something, you can integrate these techniques in any part of the treatment. Coming to the pharmacotherapy, we all know anticholinergics from edges. So all anticholinergics which are popular today are equally effective. The older ones like fluvoxate, very common, Urispas we use, but actually it has no good role. It's giving an effect of placebo. That's why it's not recommended. Coming to the dose, we all know that all the anticholinergics are coming with 2 doses. One is low dose, like for oxybutynin 5 mg, then higher dose would be 10 mg. For tolterodine 2 to 4 and derifenacin 7.5 to 15. The trospium is coming with the extended release preparation of 14 nowadays, and solifenacin 5 to 10. So extended release preparations are always better, and because they are having the equal effects, almost equal efficacy, then how to choose? So to choose between them, we have to see the side effect profile. Like few medications doesn't cross blood-brain barrier. That's why they have little effect on the CNS, and the cognitive side effects will be less, like derifenacin and the trospium. Other side effects could be dry mouth because of the effect on salivary glands, constipation, and even the effect on eyes, dizziness could be there. So in these patients, like if the patient is pregnant, breastfeeding, having hypersensitivity to the medication, you should never use these medications. And also you should ask the history of uncontrolled glaucoma. If patient is having problem of urinary retention, voiding dysfunction, and in problem of any mobility of the gut. So these are the patient where you have to avoid. Then what to do with these patients? If these things are present, then the option is mirabegron. Mirabegron, the beauty of this medication is that it actually works at the storage phase, while the anticholinergic works by inhibition of contraction. So it can affect the voiding phase, and it can actually aggravate the voiding dysfunctions, but not with the mirabegron. The dose of this medication is 50 milligram for daily at bedtime for adults. Only the patients with renal or hepatic impairment require a reduced dose of 25 mg. This medication is also having side effects, like it shouldn't be given with patients with uncontrolled BP and some kind of problem with the GI. So in this way, you can choose the patients depending on the side effect profile. Desmopressin is a medication which is particularly used for those who are having specifically nocturia. And it can be given in the form of nasal spray as well, but it shouldn't be used in patients with cystic fibrosis and in elderly group. Now, how to choose between medication? As I told, that the first line medication could be either mirabegron or anticholinergic, depending on the side effect profile. Suppose, initially patient got a response which is partial, then in case of anticholinergic, you can increase the dose. But suppose if it is not having good response, then you can switch over to other form of medication. But if both the medications are not affecting alone, then you can combine the medication as well. I was the part of the guidelines issued by the Urological Society of India, and they actually recommended the same thing, that combination is more efficacious than either drug alone. Now, if all these things are not working, then what to be done next? So it means that either your diagnosis is wrong, you are dealing with something else, or something else is present along with this thing, or this is a refractory condition. So how to do that? Now you have to see other things also. Sometimes these kinds of conditions are hidden, and because you have treated OAB, they will come up, like SUI. So you have to again check for this thing. Nocturnal polyuria is the condition. It is especially present in patients with obesity having sleep apnea, and because of that there would be closed thorax, and because of that there would be intrathoracic pressure is negative, and because of that cardiac dilatation occurs, and they secrete atrial natriuretic peptide, and because of that there will be high production of urine in night only. So because of that, you can see in bladder diary actually that there is a high production in night only. In polydipsia, because they are drinking high, their volume of void will also be high. In both the condition, that would be the thing. And of course, ICBPS, the only differentiating factor is presence of pain. So you can diagnose all these things very easily just by doing asking the patient to maintain a bladder diary. And I can share my website. I have made a video, very easy, Hindi and English both, to make patient understand how to fill the bladder diary. Now coming to the, if you're thinking that these things are not present, it's refractory overactive bladder, then urodynamics is required. And you can see here that this is the typical picture when on rise of detrusor pressure, leaking is there. But suppose it is not there. Patient is not having high intra-detrusor pressure. It's only the hypersensitivity. Patient is having sensations which are high. Then probably these are the candidates for cystoscopy. And you can see the picture like that. Like there could be ulcers, glomerations, bleeding points. And please don't hesitate. You have to learn cystoscopy if you are dealing with pelvic pain. You are a pelvic surgeon, whether you're a urologist or gynecologist. But the only thing is that you must know where you have to stop and where you have to refer this patient to the other specialty. Imaging, yes, if upper tracts are involved or if neurological deficit is there, you have to send these patients to relevant specialty. Now coming to the second line management or rather third line management of overactive bladder. Again, to do this thing, you require to learn cystoscopy, and believe me, you just need to do once under guidance of one specialist, then you can do it yourself. It's very, very easy. Initially, we start with a little dose of 100 units because it affects the it causes bladder relaxation. And also, if patient is having both the problems, overactive bladder and interstitial cystitis together, it has a very good role because it also decreases the sensation. And if we don't give 200 units straightforward, if there is less response, then only why? Because it can cause retention of urine with higher doses. So that is the botulinum toxin injection. The next would be sacral nerve stimulation, and believe me, it's so costly. It's not very popular in India because it's not covered under the TPA. Yeah, just I'm finishing. Posterior tibial nerve stimulation, that is the thing you can purchase online. It's having a good effect if a patient is not having effect of drug medications and not ready for getting botulinum toxin or anything else. So these are not recommended. And these things, believe me, I have never seen any patient with overactive bladder to have these kinds of surgeries. But yes, if required, you have to send these patients to pelvic surgeons. This is the last slide of my presentation, containment. Yes, please, if the patient is not able to cope up with the medication and all, you can utilize these things even in the time of waiting of getting a response. Not only diaper, this is a mirror valve. It is from Cook Surgicals, and this catheter is having a valve. So these patients actually can just press the button and can release the urine. So it is a temporary measure. If patient is traveling or doing something, she can utilize that thing. So that was the last slide of my lecture, and I hope I just summarize the things in short way. So thank you so much. If you want to ask anything, you can ask me. Just pause.
I had a question, Dr. Amita. Can I ask?
Yes, yes, please.
Yeah, Amita, very well presented in the short span of time. My question was to you is, what is the cost of Botox injection interstitial in the bladder? Would cost a patient? And the second thing would be, how often do you call these patients? Within the span of 6 months or?
The thing is that usually the effect of botulinum toxin remains for 3 to 6 months, but usually we don't repeat these botulinum toxin before 6 months. Why? Because if you are repeating it very frequently, there could be a kind of antibody formation, and there would be a resistance to this medication. So it has been found through studies that are 1 to 4% chances of getting this resistance. So the recommendation is that, yeah, you can repeat, but usually not before than 6 months. Answer of first question.
And the cost of getting
the cost is that presently in India, previously it was from Allergan, that is Botox was the brand name. That now Intabot is another brand from Intas. So actually they are giving it almost in half cost. The only important thing is that whatever brand you are using, it should be the type A. That is very, very important. And the cost of 100 units for Botox was used to be at 17,000. I don't know, the current they have reduced or have make it higher. And it was almost 7 to 8,000 for Intabot. That was.
Yeah. Thank you so much. So we can refer our patients to you in Medanta.
I'm only telling this is the cost of injection. They have to give the cost of my injection also. Okay.
Sure. Thank you.
Thank you, Dr. Amita. I have one question. Is there any role of any preventive measures for this condition of overactive bladder? Any long-term measure which can be done or like this?
The thing is that it's an idiopathic condition which comes with age. So nobody, like diabetes and other disorders, it's not like that you can prevent it completely, but you can decrease the severity. So just by doing a kind of following the good bladder habit, that's the fluid intake should be actually adequate and in distributed form. That is very, very important to avoid these of the conditions. And usually whatever medication we recommend is for 3 months at least, because we have seen the spontaneous resolution of this condition as well. So I think to decrease the severity, you can do something, but not for the prevention at all.
Okay.
Yes,
Dr. Neelam.
Thank you very much, ma'am. You have given a very informative and knowledge enhancing lecture in this overactive bladder in a very short time. And you have so beautifully uncovered the complaints regarding, so much confusing situations, like treatment of fungal. Yes, patient comes with the itching in private parts, but the actual problem is repeated leakage of the urine and overactive bladder. So nicely you have deliberated about all the details about these conditions, and plus very good elaboration about the treatment part, particularly the behavioral, and particularly in the field of gynecology, we are less knowledges about the drugs which are being used in the treatment of this condition. Thank you so much for enlightening us on this topic. Thank you.
Dr. Amita, can I ask you one thing? What is your take at mirabegron? How frequently you are using this drug? Because we are not so well versed with all the therapies.
So, ma'am, mirabegron is very good medication. I have seen that if a patient is already having dry mouth conditions and the constipation, my first choice of medication is mirabegron. The only problem is with mirabegron is that the effect comes little late, after 10 days. It's a slow acting agent. So if I require a medication which should promptly work, then probably I will choose anticholinergic, and my choice of drug is solifenacin, which I have seen a very good results. Though it has been said that all anticholinergics are doing the same, success rates are same.
So you start with anti-muscarinic and then you take mirabegron?
No, ma'am. If a patient is having uncontrolled BP or other complications where I cannot use mirabegron, I will choose anticholinergic. But if a young patient is coming to me with constipation and other problems where I cannot use anticholinergic, I will use mirabegron. So it's the side effect profile which will make me to choose which medication, because both are equally efficacious. I will tell patient that yes, mirabegron effect will come in 10 days. So please don't stop. Don't think that on the next day you will have the effect. So that is my counseling to the patient. And usually I ask patients.
Someone in chat box is asking the dose of solifenacin.
Solifenacin, the lower dose is 5 milligram. And if it is, usually I increase the dose once the patient is saying that at least 50% response is there. Then the second dose is 10 milligram. And it is given usually 2 hours after meals. Why? Because you cannot combine it with meals. It's a slow acting agents, and only once a daily dose is effective. You don't have to do it, give it in twice a daily dose. That's the thing.
Thank you.
It's the half is good. Half life is good.
Urmila Didi.
Yes. So we begin with our third session. Thank you, Dr. Amita. Thank you, Dr. Yashodhara and Dr. Neelam, for an excellent session. There come the vibrant third session chairpersons. Dr. Anjali Jain, she's consultant obstetrics gynecs at Mithul Memorial Polyclinic and RIMS Care Hospital, Gwalior. She's my senior, my husband's batchmate, Dr. Harshvardhan's batchmate, and an excellent human being. Hello, Dr. Kulshresht. I'm happy to introduce you. She's professor in the Department of Obstetrics Gynecology at GR Medical College, Gwalior, and she has just been the past secretary GOGS for 2019-20 session, and a smiling, ever welcoming human being. And now, please take over the proceedings.
Hello.
Yes, we can hear you.
Yeah. Dr. Navita Purohit is there? Is she? Hello?
Yes, yes,
Yes,
I'm
she
there.
is
Very
there.
much there.
She is there?
Yes, of
Yeah,
course.
yeah.
Yeah.
Okay, okay.
I'm there.
So
Am
our
I
next speaker is Dr. Navita Purohit. She is a consultant in rehabilitation medicine and specialist in pain medicine, palliative care at Kokilaben Dhirubhai Ambani Hospital, Mumbai. And she's an executive member of GIVS. She is the first Indian certified pain sonologist. She is program head of fellowship in interventional pain management. She is also honorary secretary of AIPMR. She has got multiple national and international presentations and many research publications in her name. So I welcome Dr. Navita Purohit. Welcome, ma'am.
Thank you so much. Thank you, Dr. Jain, for a kind introduction. Am I audible?
Yeah.
Yes.
Yeah, ma'am, you are audible.
A very good evening to all. And I would like to thank Dr. Urmila and Dr. Amita Jain for giving me this opportunity. My screen is visible. My presentation is visible.
Yes, yes.
Yes, ma'am.
Okay, so without further ado, I would say I'm not a gynecologist and not a urogynecologist, but I'm a pain physician. And how do I deal with the pain when my gynecologist and urologist, they send me the patients with chronic pelvic pain? Before that, yes, we all know, let us brush up our memory with the definition of chronic pelvic pain, which European Association of Urologists have given, that it's a chronic or persistent pain perceived in the structures related to pelvis, either men or women, for more than 6 months, and leading to negative cognitive, behavioral, sexual, emotional consequences, as well as with symptoms suggestive of lower urinary tract, sexual, bowel, pelvic floor, or gynecological dysfunctions. It's a very confusing definition, and the prevalence is around 6 to 27% worldwide. The challenge in treating it lies in identifying the pain generator, because if we identify the pain generator, then we can definitely treat the pain and also effectively treating the identified conditions. So when I get a referral for patient with a pelvic pain, how do I go about it? History, as we all do, history, duration of pain, the character of pain, burning, stabbing, pricking, dulling, because that makes me identify which pharmacological agent I have to use, whether it's a neuropathic pain, whether it's a visceral pain or somatic pain. Relation to the posture, because these patients, they develop a typical posture to reduce the pain. So sitting, standing, lying down, and that is why they get those myofascial bands. What are the aggravating and relieving factors? What is the severity? Because depending on the severity, we go for the management. So we use this body map, and then we give it to the patient, and they draw on the area where their pain is, whether it is localized or whether it is radiating within the going in the thigh, back, inner thigh, or inside internal. Is there any relation to the voiding? Is there any dyspareunia? And not in the first meeting, but we have to ask them, is there any underlying cause or underlying stress? In the second or third meeting, we do that. Very commonly, there is a pelvic floor dysfunction, then the internal examination has to be done with one finger, and we have to see that if there are any tight or taut bends within the pelvic floor muscles. It can occur as an inherent cause or a functional adaptation to other disorders within the pelvis, and which causes a distortion of the pelvis hip spine complex. So this is how these bands develop. Examination, it consists of looking for myofascial bands or a trigger bands internal or externally in the suprapubic area. There can be tenderness in the suprapubic, lower back, thigh. And it has been seen, Robert et al., they reported that
myofascial trigger points of the pelvic floor, it may be identified in as many as 85% of the patients suffering from pelvic pain syndrome. So it is as high as 85%. We have to look for myofascial pain trigger points. What are myofascial trigger points? So these are the localized, often extremely painful lumps or nodules in the muscle or associated with connective tissue. Myo, muscle, fascia, within the fascia. So it can be in the muscle, it can be in the fascia. There can be two types of trigger points. It can be active, which is producing the local or the referred pain, or they can be latent, which can be activated, which are at the moment not causing pain, but they can be activated by any physical or emotional or other associated stress. One more thing is to identify, because we need to know what is the cause of the pain, whether the muscle, the nerve, or the visceral. So we do a Carnet test in which we let the patient to raise both the legs and then along with that raise the head. If in this position we touch with our hand or palpate the trigger point or the pain area of pain, if it is more painful, then we are dealing with the myofascial or a neurogenic pain. And if it is less painful or the pain doesn't increase, then we are dealing with the visceral pain. So we now know whether it's a neuropathic pain or a myofascial pain or it's a visceral pain. So clues by the history, not going into the detail, but we all know if it is a hot burning electric shock, like what is more important for me, it's a nerve entrapment, crampy pain, inflammatory bowel disease. With menstrual cycle urge voiding, we are dealing with interstitial cystitis, and so on and so forth. So how do we manage? Important thing is to break the pain cycle. We all know that there is something going on in either an infection or inflammation has flared up and it has gone in the whole of the pelvis. So it is called as a complex regional pain syndrome of the pelvis, because there is a neurogenic inflammation leading to peripheral sensitization and then the central sensitization. So that is why the whole pelvis is involved, and we have to break the pain cycle at some point, and that will help us in reducing the pain. And with this, we aim for management of female pelvic pain is to alleviate the pain and improve the quality of life with pharmacological, physical therapy, psychological counseling, and interventional pain management. How do we go about with we'll deal with one by one. Pharmacological management, how can we start with the WHO step ladder pattern, which was developed by WHO for cancer pain management, but it is now widely used for chronic pain. So at the step 1, we can use any known opioids. If the pain is not getting better, weaker opioids, or step up to stronger opioids like morphine or pethidine. At any point of time, we can add the adjuvants, which helps in neuropathic pain. And the step 4 is the interventional pain management. Depending on the intensity of the pain, we can use this step 4 at any of the steps. It can be beginning, we can de-escalate, or we can escalate from step 1 to step 4. So again, if it is mild pain, step 1, which is 3 to 6, that is moderate pain, step 2. And if it is more than 6, we can use step 4 or step 3. Pharmacotherapy, it consists of adjuvants like gabapentin. EAU has given a grade 1B for this. Gabapentin, pregabalin, tricyclic antidepressant can be used for neuropathic pain in the form of amitriptyline starting with 10 mg, nortriptyline, duloxetine, or a combination of it. Because there is a pelvic floor dysfunction and a spasm is there, so we use muscle relaxant in the form of tolperisone or cyclobenzaprine or tizanidine. So this review, it suggests that gabapentin versus amitriptyline at 2 years follow-up, gabapentin was better than amitriptyline in terms of pain relief. And this is the review which suggests what should be used when. So if there is a somatic type of pain, acetaminophen can be used. If there's a neuropathic type of pain, gabapentin or pregabalin can be used. If it is not getting better, combination of gabapentin with amitriptyline, it gives better result as compared to gabapentin alone. If it is a inflammatory pain like a dysmenorrhea, NSAIDs can be used, but there is a lack of effectiveness. Cochrane review suggests that in endometriosis, NSAIDs have no role. Opioids, it can be given for short-term use, but not for long-term. OCPs, and this is what I think so you must be using it in day out. And then if there's a patient pain with underlying depression, selective serotonin uptake inhibitors, again TCAs, and there can be a combination of these two SSNRIs. And coming to physical therapy, then there is something called as TENS, trans-electrical nerve stimulation. It can be given at tender points. Again, EAU recommendation or the level of evidence is 1B with grade B recommendation. Myofascial release, you can send them to your physical therapist by saying that these are the tender points, these are the muscles which are involved, and they will release it. They can be internal massages, they can be external in the suprapubic, whatever areas. Again, the evidence is 1A, recommendation is grade A. Vaginal dilatation, graded level of dilatation can help, and EMG biofeedback for pelvic floor exercises. Again, it has a 1B, and recommendation is B for using of EMG biofeedback. If there is a pelvic floor dysfunction, if we identify, then again, there's no role of strengthening exercises or Kegel's exercises, but pelvic floor relaxation exercises is very important, because if we tell them if there's already the muscle is in spasm, it has to be relaxed, and this is the way of relaxing the pelvic floor muscles. Then third pillar is the psychological counseling, because it's a more than 6 months, it's a disease in itself. So the pain has to be controlled along with the stress factors. So cognitive behavioral therapy, it can be in the form of relaxation technique and psychotherapy. Again, EAU evidence is a level 1B evidence of psychotherapy, and the recommendation is grade A. So when we are doing whatever we are, it has to be a part and parcel of the physical therapy, counseling, and other things. Then if it is not getting better, we can go for interventional pain management. And this is what I do with ultrasound. So we identify the myofascial or the trigger points, internal and external, and use if there's an external, we can see this hypoechoic area within the rectus muscle. She had a suprapubic tenderness, and we injected it with local anesthesia and steroid, and we can guide, and we can actually see, and we are doing a hydrodilation or hydrodissection of the muscle, or this the myofascial band is getting hydrodilated and released by myofascial trigger point injection. What is the evidence? So this Langford et al., they did a myofascial trigger point injection of identified trigger points intravaginally, and they found out that 72% of the women, they improved with first trigger point injection, out of which 33% completely pain-free. So if I can repeat it after 1 week or 2 weeks, then the pain would be much better, because 85% of the patient have myofascial trigger points. So again, the level of recommendation for myofascial trigger injections is level 1A, and grade recommendation is grade A. So if not getting better by trigger points, is there any role of botulinum toxin injection into the muscles? Yes, Abbott et al., they did a study and found out that the pain relief was not that much, but it does help in reducing the pelvic pain. But the pressures on the vaginal manometry, they found that there was a great reduction in the pressure. So if there's a pelvic floor muscle spasm or dysfunction, then we can also go and do botulinum toxin injection into the pelvic floor muscles, or identify those. Second thing is pudendal nerve block. So there are pudendal neuralgias in CPP, also pudendal nerve entrapment within the myofascial bands, and they do very much. They do much better with pudendal nerve block, and it has been identified as a nerve block in EAU guidelines. How do we do it? We identify the pudendal nerve with ultrasound at the level of ischial spine before it enters the Alcock's canal, and this is the needle which is injecting here. We identify the pudendal artery. Medial to the artery is the nerve. We all know it, and we inject it around the nerve. Now, because there is a central sensitization and also there is a crosstalk between the sympathetics. So blocking the sympathetics can help in reduction of the pain in the pelvic area. So superior hypogastric plexus block, which is a sympathetic chain at the level of L5S1, which supplies all the pelvic organs. So if we block this plexus, then we have a good results. And the indications, the first indication again is the chronic pelvic pain. So we can do a superior hypogastric block. So and again with the help of a ultrasound, where we can identify the level of L5. There's a the iliac vessels are dividing, and that is the area where we inject or injected. We can use local anesthesia and steroid, and the people they do good. Then at the level, if there is a lower anal pain and the clitoral pain, so if there, we can also do a ganglion of Walther or the ganglion impar block, which is the last ganglion of the sympathetics, and we can block that. And this study was done in Poland, and it's a case report in which they did neurolysis using alcohol, and they did get better results in all the patients who had in both malignancy as well as non-malignant origin, and they had very good results and very good pain relief. There was in fact, in 4 cases, there was a complete and permanent cessation of pain with no complications noted. So it is also, it can be thought of when the pain is more on the rectal area or in the anal area. So, sorry. Neuromodulation, we all know sacral neuromodulation, it plays an important role, and the success rate is 72% at median follow-up of 61 months. Then we can also go for pudendal nerve, peripheral nerve stimulation, and it was done in 84 patients, in which 42 patients they did much better, mostly for the interstitial cystitis, but even for the chronic pelvic pain, it has been recommended. Dr. Amita just spoke about percutaneous tibial nerve stimulation in overactive bladder. It has very good role. Even in ICBPS, it has very good role. 100% of the patients, they get relieved. But even for chronic pelvic pain, it was studied. It is a case study done by Nidhi Sharma and et al. And they found out that the patients whom they took up for this chronic pelvic pain, they were completely pain-free after this percutaneous tibial nerve stimulation. So again, EUA guideline, what is the recommendation? Paracetamol, we have already known for what. So we have this, and for the nerve blocks, it is, there's a evidence is level 3 and recommendation is C, but it has an important role as a broad part, management part. So we can use it when we are doing along with our cocktail therapy of maybe paracetamol or neuropathic painkillers, along with a nerve block or a myofascial trigger point, and along with the physical therapy, along with cognitive behavioral therapy for improvement in the outcome and improving the quality of life. So this was the algorithm of pain management given by EAU. So if the pain is neuropathic or central pain, if it is not central pain or neuropathic pain, simple analgesics can be given and then reviewed. And if we see if there's an adequate analgesia, nothing to do. If there's an inadequate response, then refer to pain specialist. If there is a neuropathic pain or central pain, then start with first line management like this amitriptyline or gabapentin, or you can use alternatives like nortriptyline or pregabalin. Call them back. If there's an adequate analgesia, then you can consider reducing the dose. If there's an inadequate response, consider adding another first line agent, rotate the agents. You can use duloxetine and other agents. If still, you call them back, and if still inadequate, then refer to a pain specialist for doing some blocks. So that is how we go about it, starting from step 1. So that is my algorithm. This is how I go about when a patient of a chronic pelvic pain comes to me. Important thing is assessment and assurance is most important, in education, that it is a time-taking procedure. It's not that one go and things would be okay. It will take time. There will be flare-ups. There will be waxing and waning. So we have to educate and counsel the patient at every step and take a good history physical examination. Start with the first step ladder. If the and depending upon the pain, what is you can start with weaker opioids like Tramadol or Tapentadol, and add the neuropathic pain adjuvants like TCAs and gabapentinoids along with the physical therapy and cognitive behavioral therapy. If the patient comes back, patient is not relieved, we can start like more fentanyl. Fentanyl patches, they are very helpful in that, and even only for a not for a longer period of time, and think about giving them trigger point injections along with the neuropathic painkillers, physical therapy, and cognitive behavioral therapy. If you find that if they come back to you and it's like a entrapment of the pudendal nerve, go for a pudendal nerve block along with the weaker opioids and all the other things which we had already started. If not getting better, go for a superior hypogastric plexus block along with all the adjuvants and NSAIDs or all weaker opioids or a stronger opioids if we have started. Also start percutaneous tibial nerve stimulation. So everything done together it's actually a teamwork and a patient-centric approach in which gynecologists like all of you and urogynecologist or a urologist, pain physician like me, physical therapist, counselors, psychological counselors, all of us, we work together for improving the quality of life and decreasing the pain of the patient. So I was summarized by saying that pelvic pain is a very challenging, it needs a multidisciplinary and a multimodal approach. The role of trigger point injections, it has been established, but we still need to establish the role of superior hypogastric pudendal nerve block, peripheral nerve stimulation, percutaneous tibial nerve stimulation. They have a potential role, but we need good studies for establishing their role for improving the quality of life. And I would say that all of us, we work for relieving the pain relief, and which is a basic human right. So it's a privilege to treat pain for surely. And all of us, we work for smiling pain on our patient, for putting a smile on our patient. Thank you so much. Any questions, I would be happy to answer.
So, hello, a very good evening to all of you. So, am I audible?
Yes.
So, first of all, I would like to congratulate Dr. Navita Purohit on such an elaborate illustration on interventional pain management, pelvic pain management, which is still an enigma for all of us. As they say, once a chronic pelvic pain patient is always a chronic pelvic pain patient. The topic as such is very, very complex and symptoms are really difficult to treat. Thank you, Dr. Navita, for clearing our doubts and sensitizing us on advances made in the field of chronic pelvic pain and its management, and the importance of differentiating between the neuropathic and muscular pain, telling us about the ultrasound guided pudendal nerve block and hypogastric plexus block. And I would also like to forward my thanks to the organizers for making me a part of this prestigious webinar. Thank you, Dr. Navit, for an elaborate and nice presentation.
Thank you.
And also, I was told yesterday that you were not well, and so you still, it doesn't look as such that you were not well yesterday. And so, congratulate you.
Thank you.
Yes, Dr. Navita, even I was surprised that you, after knowing your condition, I was thinking that you won't be able to come. So
yeah, that's why I asked whether she has joined us or not.
So actually, this is so close to my heart. So I thought I should not miss the opportunity.
Yeah. Take care. Take care.
Thank you. Thank
right
you.
Yesterday, I'll be there. So I was completely at ease.
Okay.
So now coming to okay. So there comes our final session of panel discussion. And I heartily welcome Dr. Veera Raghavan. Veera Raghavan is one who I had taken a fancy right when I heard her first talk 4 or 5 years back at Mumbai. Welcome, Dr. Veera Raghavan.
Hello.
And hello. I'm so glad to welcome you in Gwalior webinar.
Thank you very much for this opportunity.
Yeah, it's a dream come true, though virtually, but then we are having the pleasure of it all. And I would like to introduce, she is an executive member of GIBS and is senior consultant urogynecologist and robotic surgeon at Apollo Hospitals, Chennai. And there is so much more to her bio sketch, but she'll reveal herself as she moderates our session. Welcome, Dr. Veera. And now you can introduce us all. I'm already introduced the rest of our panelists.
Sure. Thank you very much. Thank you, GOGS and GIBS. It's a wonderful combination here. And happy to see and connect with all my friends, though virtually. Hello, Ranjana Madam, Amita ji, Navita ji, Urmila ji. Hello, everyone. And hello to everyone from Gwalior. Thanks to Deepthi and Cheshta. I'm just going to introduce the panelists here. Dr. Ranjana Sharma, extremely friendly, very senior colleague from Apollo, Delhi. Welcome, ma'am. She's an asset to both the field of urogynecology, gynecology, name it, she will be there in the panel. So looking forward to hear from you. Dr. Urmila, very good friend, energetic person from Gwalior, as you all know. Dr. Amita, you've already heard her, and she will speak for herself. Dr. Navita, very different angle to the whole thing, what we are managing. A good friend to have. Please note her number down. She's very approachable. She'll save you when your patients nag you. So there you go. Dr. Charulata Mittal. Hello, ma'am. Consultant Obs-Gynae Gynae from Gwalior. And Dr. Vrinda Joshi, Professor and Head Department of Obs-Gynae Gynae. Welcome, ma'am, for the panel. So this is not my presentation. I've been promoted from panelist to moderator in the last minute. So I'm going to share the PowerPoint. So I'm going to ask the questions and I don't need to answer, hopefully. So let me see.
Privileged position you are in.
Indeed. I don't know whether I've earned it, but nevertheless.
You have.
Just 1 second. So everybody's able to see the slide now? Yeah. Going to make it as a slideshow. Can you confirm? You can see that in the PowerPoint.
Yes, ma'am.
Yeah. Okay. So first case, 33-year-old with pain in the lower abdomen and pelvis for the last 1 year with exacerbation of pain during menses. So all this is about discussing the various differential diagnoses of chronic pelvic pain, whether we are in the right angle of diagnosis and management, what should we be thinking when we are dealing with such patients, how we can help them both symptomatically as well as to diagnose and manage the root cause of the pain. That is what it's all about. So no vaginal discharge or abdominal bleeding, unable to function at times due to the acuteness of pain, dyspareunia, and impaired quality of life, and multiple hospital admissions without much relief. And bowel and bladder, normal. Menstrual history, regular heavy flow with severe dysmenorrhea, undergone laparoscopic endometriotic cyst excision with adhesiolysis 4 months back, ureteric stenting done at the same time for left ureteric obstruction leading to grade 1 hydronephrosis by IVU and stent removed a month back. No other medical illness. Examination, normal. Vagina and cervix healthy, uterus retrofitted, fixed. lateral cervical displacement, acute tenderness and mass, and fibrosis in the upper left vaginal fornix, right vaginal fornix free, rectovaginal region normal. So, to the team, Dr. Urmila, what would be the various differential diagnoses we would be thinking of at this stage?
The case is very clear. The history is very evident. Long-term dysmenorrhea and pain in abdomen, and for which she has already undergone laparoscopy, which is said to be the gold standard for the diagnosis for endometriosis. And they have already operated upon a chocolate cyst of ovary, which is ovarian endometriosis, and as well as ureteral stenting, because perhaps the adhesions were encroaching upon and obstructing the ureter, which was removed 1 month later. And she has undergone an operation, but still her tenderness and mass and pain has not been relieved. Yeah. So of all these three, I think it is post-operative adhesions to which it points, because endometriotic cyst has already been removed.
Could it be a recurrent endometriosis?
But it's a very recent operation, 1 month back.
4 months. 4 months.
4 months.
I wanted to ask Dr. Meera whether after operation she was given some medical management for the prevention of endometriosis.
Doesn't look in the history. That's what I was going to come to, but I wanted the panel to pick whether you have picked that out. There's nothing mentioned about adjuvant medical therapy, which is why this pointer in the findings as mass could be a recurrent endometriosis rather than just adhesions.
How old is she?
33. 33.
This appears to be a case of endometriosis, which is a very common presentation in endometriosis. In all ages, even with the removal and excision of endometriotic chocolate cyst, we have to counsel them beforehand only that this particular surgery is not going to relieve you of endometriosis ever in your life, however sad it may seem so. And that is a very common picture that we present. And again, it's very difficult to manage these patients because there may be n number of treatments which we are giving for endometriosis, like starting from Dianogist to LNG, IUD, to giving GnRH analogs and all. They work for some time, but they all have their own side effects. But yes, they usually will be helpful in this patient.
At least for prevention of recurrence to some degree, because we need to actually counsel these patients when we do surgery. This is not a one-off, that this is going to be a recurrent issue, and they might need adjuvant therapy, or at least can come back for issues pertaining to endometriosis yet again. So yes, we agree that there are two diagnoses now. One is post-operative adhesions, but more likely it could be a recurrent endometriosis. I'm sure the panel agrees on these lines. So moving forward. So with the investigation showed complete blood count, urine routine and culture, ultrasound left ovary adherent, septate cyst with internal echo seen, and CT image showing a mass in the left hand nexa. So if the urine routine and culture were normal, we would have ruled out infection and other sinister causes. So we now have a CT image of a mass in the left hand nexa, probably indicating our diagnosis could be a recurrent endometriosis. Agreed?
Yes.
Agreed.
Because I have minimized your gallery view, I'm only able to hear voices. So, so we have understood now that these possibly could be the recurrent endometriotic lesion. If we didn't have the first three diagnoses, it will be Dr. Navita's patient, I guess. Isn't that so, Dr. Navita?
Yes.
Even
I'm sure it will be. By the time we break our heads in the third sitting for this patient, it will become Dr. Navita's patient. So what would be the pointers towards differentiating between the first three, and when we would call it something we have to pass it on or involve a pain specialist. Dr. Brenda?
As it is, since the first laparoscopy has been done and they have found an endometriotic cyst which has been duly removed, there could be a second look laparoscopy done in a patient if she is having intractable pain. And as you said, there is a palpable fibrotic area in one of the fornices, probably left fornix. So a second look laparoscopy will make clear whether it is because of some adhesions or it is because of the endometriotic patches, which this time probably appear to be on the uterosacral areas of the left side. So that is one way of finding out adhesions. And for ureteric colic, of course, maybe I would refer it to some nephrologist.
Urologist, you mean. So what imaging techniques would or signs you would look for when you're going to differentiate between recurrent endometriotic lesion, adhesions, or ureteric colic? Dr. Anjana Sharma, please.
Right. So one thing, Meera, just I want to know her obstetric history.
That's not mentioned in the first slide.
Zarin, I think she got.
No, it's not mentioned.
Doesn't say that, right? Because endometriosis, the treatment of endometriosis in a person who's trying for a pregnancy is totally different from someone.
Yeah, let's assume she's nulliparous to make ourselves
let's
even
say
more
she is
difficult.
Okay, let's say she is nulliparous. So, so whenever you are in doubt, you can do MRI pelvis with contrast, throw light on it, and adhesions. You know, even if adhesions are there, you don't want to do an investigation just to confirm whether there are adhesions or not. Because if there is endometriosis adhesions, you presume that they are, right? And now ureteric colic, the symptoms don't look like ureteric colic.
Yes.
One thing, and if you want to confirm by imaging, your MRI might tell you, but then a simple X-ray also can throw some light on ureteric stone, if you are thinking of that, right? Yeah.
I just want to add, like even for MRI pelvis, if you are getting with contrast, late films actually give a picture of MR urography.
Right. Yeah.
You can combine and you can see actually if you want to see the urinary tract. You don't need to radiology.
Yeah. I think more than ureteric colic, if there was a hydronephrosis due to the scarring and the fibrosis which has happened, that would be visible on all ultrasound itself. So we can rule that out because she had a left-sided stenting. And in endometriosis, it's not the direct impact of the endometrioma, it's the post-operative scarring which can give rise to hydronephrosis because of ureteric entrapment. The other thing I wanted to mention is we can use a simple 3D ultrasound when you do those probe-related to find out adhesions, especially in and around the recto-uterine pouch or the vesico-uterine area. You slide the organ, and if there is no independent sliding when you do the 3D ultrasound, then you can make out these adhesions are probably there. You don't need a diagnostic laparoscopy for that. And in this patient, I don't think there is any game for diagnostic laparoscopy because we need to go in with an intent to do something, because we know even a diagnostic laparoscopy increases the chance of recurrence of endometriosis.
No, and more so, see, why I asked you whether her obstetric history, because once she's had a laparoscopy and cystectomy, we know that we have reduced her AMH and the ovarian reserve. So second laparoscopy, we would like to postpone as much as possible. So that be the final laparoscopy.
Yeah, we would rather get on with the fertility related issues if that is the case, rather than endometriosis treatment per se.
That's right.
Absolutely, ma'am. Thank you. So what would we decide as a panel if we were to be in this dilemma? Repeat the laparoscopy or do something else?
Question is to whom?
So I think that we should do some markers as well, because
can we be I'm not able to hear, ma'am, sorry.
I'm Amita.
Hi, can't hear you.
So Should I
It's better
write?
now. It's better
Yeah,
now.
that's better now. If you're speaking to the mic.
It's a kind of cyst with adhesions. Why not go for tumor markers as well? Because something new can also happen apart from endometriosis, even to see the CA125 level right now, just to confirm that it is going to.
Is it something which is going to make us any wiser?
Yes,
because
if there is some kind of tumor marker, alpha fetoprotein or something is high, it could be a completely different diagnosis.
So that's part of
workup of
investigation. Okay, fine. Dr. Charulata Mittal, now that we know that the CA125 is within the endometriosis acceptable range, we still see a 4 centimeter cyst or a mass, whatever. What would be the suggestion for this patient? There are two options here. Let me be the devil's advocate, make her nulliparous. What would we suggest?
Ma'am, since it is again a cyst is there, I think we have to remove it. But yes, up till 5 centimeters, we can try the medical management.
Yeah,
And
which is
there
why
are
I said
reports-
nulliparous and 4 centimeters. So
Yeah, so reports are there of the suppression of the cyst below 5 centimeter size. So the first approach would be conservative since she's undergone a recent surgery. Then I think we have to offer her this as a first line and see within the next 3 to 6 months if there is a regression of the cyst and her symptoms.
Okay.
Before straight away going for another operative intervention.
Agreed. Totally.
Meera, I think we have
may
to
I
be...
speak? This is Dr. Vrinda.
Yes.
If we consider her as an nullipara who is wishing to be pregnant, then the scenario changes a lot. Because in the first laparoscopy only, they might have seen the tubes as well.
Yeah.
How they are like. And then so far she has not been able to pregnant. That is evident if we take your word. So in these situations, it would be better to concentrate more on getting her pregnant by whatever kind of infertility management we want to do, and allowing or asking her that this pain, though it may remain, but there is no permanent treatment for it, considering it is endometriotic most probably. So let us try and concentrate more on your ovulation and fertilization, and getting pregnant itself might be a treatment for your endometriotic pain.
Absolutely.
So Veera, I think here we have to be very clear. She's had one laparoscopy and we don't have the full history here, but we treat endometriosis in such a case for two reasons. One for pain relief and another one for fertility.
Correct.
Right. So, these two will be the reasons, and the treatment will be if she is not married. Okay, it doesn't say here married and
Yes, nulliparous doesn't mean. Yeah, I agree.
Yes.
So we don't know nulliparous means what. She's
absolutely
single.
valid. I was going to comment on that.
So if she is single, I say if she is single, then our aim is to make her pain free.
Yes.
And how we make her pain free? We try, antiprogestogens like Dynogest or whatever we can try, and with that we can also add some other painkillers, and if that gives her pain relief, our purpose is solved. Right, and we keep an eye on the cyst, a 6-monthly ultrasound, and nothing more than that. Right.
Absolutely.
If the pain is very acute, then we can start with GnRH analogs and then switch to anti-androgens. That can be done. But so this is for a person who's not trying for a pregnancy. Right. One person who's trying for a pregnancy, we should actually have a low threshold for induction of ovulation. Uske baad, if that doesn't work for 3 to 4 months, you try that. You switch to IVF or something. Suggest to them. So laparoscopy is not on the
cards as yet.
Not on the agenda. Quickly, ovulation induction and get her pregnant. If that doesn't happen, then send her for IVF. And for ovum collection, 4 centimeters endometrioma can be ignored.
Absolutely. That's really clear, Dr. Ranjana Sharma. So the two main determinants for treating this patient will be her symptomatology, especially pain, which we have understood from the first slide. It is troublesome, multiple admission, quality of life, affliction, so on and so forth. The presence of endometrioma, the size of it would not matter. especially considering the fact that this is a recurrent one and the choice of a second laparoscopy is lingering large. So if the patient is not willing a family or not starting a family, it will be medical treatment if to get her symptomatically better, or go in for fertility enhancing treatment or ART, ignore the endometrioma because of the size and get on with the fertility treatment. Absolutely clear. Thank you very much.
Dr. Veera, rather I will tell this patient that because she is having a active endometriosis, she should get married and she should complete her family.
Amita,
that's like
to a marriage, right?
You have to tell patients.
She should get pregnant. Yeah. That is the.
We can tell her she should think of family.
Hand in hand.
Yeah. We should think of family. I can't tell her whether she could get married, but she can have family.
Yeah. That's the actually counseling should be done, because
absolutely
they can't come with infertility and all those kinds of problems. They must know that if they are dealing with this disease,
they cannot leave it till 38, 40
they
and
should
then
get pregnant.
Yeah.
Okay, point taken.
So basically this was to get into the important aspects of careful evaluation of good history, and also having a thorough examination and understanding the differential diagnosis, take into account the social factors which we are discussing now, counseling the patients with regard to pelvic pain. And disease may be treated, but pain can linger and may need prolonged treatment with different speciality. So setting the realistic goals and also understanding it will be a multidisciplinary, multimodal treatment rather than surgery being one of the options for every single time she comes in. So second case, 46-year-old with complaints of pelvic pain, dyspareunia, vulvodynia, unable to do any physical activity since 7 months. Undergone vaginal hysterectomy with anterior and posterior repair 10 months back. Multiple visits to primary doctor and others have failed to relieve her symptoms. No history of vaginal discharge, urinary symptoms, no constipation, feeling low and irritable. 2 full-term normal vaginal delivery. Second was a forceps, prolonged second stage and big baby, followed by postpartum depression. Last childbirth 10 years back. No wonder she had a prolapse. No medical illness, undergone vaginal hysterectomy due to pelvic organ prolapse, comfortable till about 3 months, started experiencing pain in the pelvic area, unable to resume full sexual intimacy, gradual decrease in activity due to constant pain, multiple visits, felt alienated so as to live with pain as no one understood. This is a very, very common scenario. People cry because they're not able to discuss, because everybody judges that she doesn't have it in the body. It's all in the mind. So what are we thinking of at this stage? Dr. Charulata?
Ma'am, it appears to be mostly maybe some nerve entrapment could have occurred and some fibrosis is causing the problem now, since she has undergone a recent surgery.
Okay.
And the other symptoms are kind of correlating with this aspect.
Okay. Anything else we would want to ask at this stage with the history?
We have to rule out the PID. Sorry, not the PID, the UTI part of it, but that doesn't seem to be from the symptoms which are there.
Anything else we routinely ask, but we need to ask more so in this kind of a patient, especially as a urogyne perspective? Here we have a sexual component is there. Prolapse component has been dealt with. 2 more pelvic floor problems have not been asked or dealt with. Bladder and bowel.
We can ask the symptoms related to that, yeah.
Yes, because of urgency, incontinence, voiding dysfunction, and bowel related, or pain during both. That also is important. Yeah. So examination, normal appearance of vaginal tissues on visual inspection, negative Q-tip at the vulval vestibule, vaginal vault healthy, spasm before one finger inserted in anticipation, pain and increased perineal tightness, non-diverting attention spasm settled, allowing the examination, but sluggish episode muscle contraction on and partial relaxation on command. So there is some relaxation, but partial relaxation on command. So she opened up about the post-delivery trauma after a second child, History of child abuse, paternal uncle trauma was still deep-seated. Good sex life with no pains, but post-surgery she was not comfortable. Felt like a loss of womanhood and feeling that her husband was ignoring her. All the above manifested as stress with insomnia, anxiety, and depression, contributing to an overall impact to her quality of life. Are we dealing with a PTSD kind of syndrome, or is it organic? How do we go about managing this patient? Dr. Urmila, please.
Yes, ma'am. The whole history and the sequence of story points to a non-organic cause. You see, even if you try to relax her, there's a component of vaginismus. Maybe her old trauma has recurred with the knowledge that now she doesn't possess a womb. Actually, they should be told the whole anatomy. It is only the uterus which we remove, and the vagina and clitoris, and that part is unaffected, and her sexual intimacies will not be affected because of the operation. But perhaps they are not very clear about it. And her husband, we had a case. I remember a case when she was a patient of endometriosis, clinically diagnosed about 30 years back. No other confirmations were there. She was under treatment. So I said, while you are having acute pain, try to have abstinence for a short period till you are getting relief. So she said, no, he doesn't, it doesn't matter to him. He doesn't disturb me, or it doesn't. So one of my colleagues who was 10 years senior to me, she said, maybe the problem lies there. It doesn't matter to him is a trauma to her. You understand?
Agreed.
She thinks he's losing interest in her because of her physical condition. And that loss of attention is a precipitating cause for perpetuating her pain. This is my stand. Maybe psychological thing, which we have to deal with the proper couple counseling.
Yeah.
And counseling session, showing her how to relax, pelvic relaxation exercises, yoga, taking interest in life, and things like that.
And this is something we do not regularly probe and directly, discreetly ask patients. There are 4 pillars of pelvic floor: prolapse-related symptom, bladder, bowel. We are all comfortable noting down these things, but we never ask about sexual function and dysfunction-related questions. It is a must that we ask, and we need to probe in better, because many of the other symptoms will not be fitting in. When we come to this determinant, we probably will be able to explain why the others exist. This is something we routinely notice. And do not be inhibited to ask even to a 60 plus old patient, because we cannot assume that many of them are not sexually active. In fact, majority of them are. So this is something we need to understand as practitioners, and also to educate our trainees, because they are inhibited to ask these questions. We need to role model by example to ask these questions as a routine. So case highlights the significant importance of psychosocial element of pelvic pain. Following surgery, she developed reactive pelvic floor spasm, vaginal and back pain, sensitization of pelvic tissues. So she bears a tag saying, I'm Namita's patient. So how will you deal with her now?
Yes, so this
Dr. Namita.
Yeah, so it looks like a pelvic floor dysfunction because of the trauma and the stress, and she has undergone, and there is a history of sexual abuse in her childhood. So it's very common that they don't open up, and they do develop this kind of picture when they have a childhood trauma or a abuse. So important thing is pelvic floor relaxation. And if she has been having this for a long period of time, it's been chronic, so she must have developed some trigger points or a myofascial bands within the pelvic muscles internally, as well as suprapubic area, or it can extend, if not treated, it can extend to the back, in the thighs, and then we have to explore for that, we have to do an internal examination, identify the muscles which are the taut bands, and important thing is talk to them and reassess and reassure them that this is something which will take time. And when she has opened up that there is some trauma, then even a cognitive behavioral therapy or psychotherapy plays an important role in this.
When she
start,
can I add something here?
Yeah.
All right. So the thing is, it's very nicely Navita said, talk to them. So mostly, what happens, they go with this problem to a gynecologist and they are treated for PID, vaginal tablets. So she changes one gynecologist, she goes from one gynecologist to another, and multiple gynecologists, multiple tablets in different forms, but nobody, has time to speak to them, explain to them. And sometimes people think, if you tell them that they have no organic problem or no physical, detectable problem, they will get upset. No, many times they are very receptive. That, if you explain to them what the could be, there is no reason, there is no PID, there is no no mass or no something which I can remove and make them better. No infection. One thing, infection. They are so worried कि उनको infection हो गया है.
Yeah, there are only two things: infection, cancer. You rule that out. They're very happy and relieved.
दोनों नहीं है. And then you just need this, need that. So they are quite, you have to counsel them, speak to them, talk to them.
Yeah, I fully agree. They get so they feel validated once you acknowledge that it is the psychological stress which is manifesting, and they're so happy that it takes a specialist to acknowledge what they're going through, and they feel very thankful for it. Thank you, ma'am, once again for highlighting that. Dr. Navita, if you were to examine, can you briefly tell the quick markers where you would concentrate when you're examining this kind of a patient? So as a learning point for us as gynecologists to look for these parts in kind of, addressing what the issue is.
So internal examination, I think so everyone, you are much better than what I would say. So all the, it's like a clock system, superficial and deeper. What are we doing? It's a levator ani or part of the levator ani or the histocavernosus or bulbospongiosis. What are we dealing with? So we can identify where exactly are the taut bands, and we can write it down so that if we are thinking of all of a sudden, if you tell them that we have to release it with some injection, so it is not possible. So we have to give some internal massages and nowadays it's like a self massaging techniques which they can do rather than relying on the therapist. So they can be taught, the therapist, they can teach them whenever they get this type of spasm, they can do a self relaxation technique. And so for examination, we do an internal technique as well as externally, we have to do a body map. And first we tell them where exactly is the pain, and then we do our examination, suprapubic tenderness. There's a lot of suprapubic in the internal thigh and the back. So we have to see, and sometimes when they say that there is a anal pain also, then we have to do a per rectal examination as well, so that to see that what part of the area is taut. And we have given injections in few of the patients, one or couple of patients in that area as well. So once when we have identified, we tell them that this is the cause, this is where you are having these bands, this is developed because of the certain the procedure which you have gone through. So they take it very well, as Dr. Ranjana has said, that they take it very well, and then they follow it to T, that yes, I have to do this. You have to tell them, and very important, we forget to tell these patients, they also dietary control is very important. If you tell them some spices or some chocolates or some fizz drinks, they increase your pain. If you ask them, they will say okay, yes, they recollect and say yes, maybe some wine or spicy food, they increase my pain. Whenever I have taken that, they increase my pain. So you have to talk to them. Voiding, yes, bladder and bowel we always forget, so we have to ask them about their voiding history and develop a voiding diary. And also now how do we deal with them? We have to speak to them regarding the psychotherapy or counseling in that same session. Then we start with some neuropathic, if it is, what is the kind of the pain, the character of the pain, and we can start the analgesics depending on the severity of the pain. We can start straight away with weaker opioids if it is moderate degree or severe degree of pain, and with some muscle relaxant, because there's a lot of muscle spasm. So muscle relaxants, they do help a lot along with the analgesics. And if there's a neuropathic pain, if they have some tingling, some burning, say they say it's a burning sensation, it's like very much, or a tingling, or a stretching, or a cooling sensation. So then we have to start some gabapentin along with amitriptyline. It gives very good results at low dose. We have to tell them, because they the constipation and diarrhea, they have to avoid that. If we are starting them on amitriptyline, then we have to tell them that it might cause constipation. We have to give them SOS laxative along with that. So and send them to the physical therapist, giving them the chart where exactly we want the massages to be done. So release the myofascial release to be done. We are starting the neuropathic painkillers or the adjuvants. They also develop, they help in the psyche. Amitriptyline, it is in also an antidepressant. So it helps in that, also in their mood elevation. We ask about the night sleeps, what is their stress history, and then send them to a counselor for cognitive behavioral therapy. So we have started the medications, pharmacological management. Then we have written a referral to a physiotherapist to start TENS and in myofascial
counseling as well,
and cognitive behavioral therapy.
So it's a multi-pronged attack.
It's a multimodal approach. They can come back, and then we can think of interventions. In the first go, I think so intervention is not the right way. We have to start with conservative management. Wait for at least 2 to 3 weeks, because it will take time, and they have to come back. We'll give them the option of the interventions at some point of time. If it is not getting better, we can do trigger point injection, which definitely gives them relief. So
okay.
Dr. Veera, just want to say one thing, that I admit I am completely agreeing with Dr. Ranjana. The first thing should be that you should counsel the patient that yes, you agree this is a problem and you understand the things, and then just counsel that yeah, it will require time, multimodal therapy, so that patient will have belief in you, because most of these patients are just having a very negative impact towards life, because no of the family members, nobody is understanding them. So that is the most important thing, I think, to start any kind of treatment, because it's not going to happen in few days or few months. It will take time. So I think this is the best thing Dr. Ranjana explained. The counseling.
In this particular patient, you know, we were dealing with a vulnerable patient.
Yes.
Who had depression after delivery,
and the
was
abuse and
childhood.
things like that.
So she was a very vulnerable patient for all these things after, especially hysterectomy.
She was high risk.
Hysterectomy, trauma, big trauma, psychological. And then she's also approaching menopause. What is it?
Absolutely.
So many things are happening in her life at the same time. So better counsel, as Amita was saying, counsel before doing any surgery. You win really if you can just explain these things before surgery, before a hysterectomy.
Looks like this patient has been to Dr. Navita, because this is exactly what Dr. Navita said as well before the slide. So we now allow them to self-dilate themselves with vaginal trainers or dilators. My physical therapist or the physiotherapy department has a dedicated pelvic floor physiotherapist who teaches them, and they can take it home and they do it, and the husband can also help. And it's about couple counseling, as you rightly put it. And first of all, as Dr. Ranjana and Amita ji said, it's about acknowledging the fact and addressing the primary issue, and not treating with empirical treatment without even having a systematic examination. Then the patient loses faith in the system and the cohort of doctors she's visited. So that is for us, the specialists, to take it up in a systematic way. So after 3-4 months of personality showing a changed behavior pattern, more confident, pain had decreased, and she was able to get back to a routine. She was enjoying a pain-free sexual relationship with her husband. She continued the biopsychosocial management program. So a prescription does not necessarily mean medicines. It's probably all this. That is the take-home message from this particular case. Hope our panel agrees with that.
Yes, absolutely.
Yeah. So this is exactly what Dr. Ranjana was telling. She was a red flag right from the beginning. And we need to probably think of it in the pre-operative session itself, or even the pre-delivery session itself, that these patients will come up with these issues, and be warned that we should not just bombard them with medications. They probably need counseling and a multi-pronged attack. Third case, 38-year-old female homemaker, burning micturition, pain in the lower abdomen, more like lower urinary tract symptoms, partly relieved on bladder emptying, increasing frequency with small voids, intermittent episodes of complete silence, narrates aggravating factors, especially spicy food, pain intensifies post-sexual activity, completely free of pain past 14 months, including pregnancy and postpartum. Are we dealing with recurrent UTI? What are the markers here which probably say it is not just UTI? Dr. Amita?
Okay. So the thing is that the pain is partly relieved on bladder emptying and intermittent episodes of complete silence. So usually for UTI, you have to diagnose the patient with, the reports, and also without medications, it's not going to relieve the first thing that. And usually this aggravating factors is spicy foods and all these things. This is showing that there is something persistent which is coming back again and again. So for diagnose UTI, because pictures are quite similar, we must have a urinalysis. It should be diagnosed by investigation.
Correct, correct. So childhood was not free of symptoms in school days too, especially pain and nocturia and frequency, no bowel complaints, two full-term normal vaginal deliveries. So I would like to know further factors which are aggravating the pain or relieving the pain. Dr. Ranjana Sharma, anything specific we want to know about from this patient to make us, channel ourselves towards a diagnosis?
So I would like to have a better urinary symptom history. So I'll take the detailed history. See what all she has with whatever you have written. Like there are no obstructive symptoms, and there are no incontinence episodes, and okay. So and whether she wakes up in the night, whether how many times she goes to the toilet in the day. Sometimes, what they say, frequency, pain, and nocturia, it says from school days, right? So, yeah. So we also want to here tell all the audience who are listening, just highlight this point, because there could be, this could be a case of interstitial cystitis. So one question we want to ask all of them, why they want to go to the toilet when they have a frequency, daytime frequency, why they go to the toilet? Because it's a fear of leaking, that if they don't reach the toilet in time, they will leak, or it hurts when the bladder filled up or there's urine in the bladder, it hurts. So if it hurts when the bladder is full and it gets relieved after emptying the bladder, it's more like points towards interstitial cystitis. And if it's the other way around, it may be an overactive bladder, one thing. Then in the night, if they have a very comfortable sleep, in the day, whatever happens, but in the night, they go to sleep and wake up in the morning and pass good amount of urine. So that also, in a way tells us about good bladder capacity. And when they are not alert, they don't have to rush to the toilet, and full bladder doesn't hurt them. But if they wake up in the night with pain and go to the toilet, empty the bladder, and the pain gets relieved, then it points towards interstitial cystitis. So, and if they have any obstructive symptoms, like they can't pass urine freely and it comes, they take a lot of time to initiate the voiding, and then they take a longer time to finish. All this can also, tell us something about what's going on.
Yeah.
Yeah.
So
thank you.
This is what we have discussed now, whether it has a pain, location, radiation, GI symptoms, GU symptoms, and dyspareunia, as to rule out any attendant issues around the reproductive system as well. Clinical examination, she had suprapubic tenderness on deep palpation, Q-tip test, vulvodynia, PV examination as one enters the introitus, and deep palpation, anterior wall tenderness, complete discomfort with vaginal spasm. We're going to suspect whether it is a bladder pain syndrome. So it's not just external genitalia. You would do a thorough examination of the vaginal follicles, especially the bladder base, and find out whether there is pain or on deep palpation. Dr. Amita ji rightly pointed out, Dr. Urmila, would you be wanting something else before you go into the test per se? Would you want to see her with something else as to find out whether we are dealing with a bladder pain syndrome?
A routine ultrasound is an indispensable investigation to rule out other causes. Yeah, coexisting causes. And the bladder capacity.
Yeah,
we get an idea of that also after like post-void urine, how much is the retention?
Yeah.
And
so a pre-void and a post-void will tell us how good is the bladder emptying plus the possible bladder capacity. And we also want to highlight the importance of food diary and bladder diary. This is very important, where you note down how much they are drinking, what types of fluids they are drinking, whether they have small bladder capacity, good capacity, what's the frequency, and whether they have nocturia, so on and so forth. It gives a lot of wealth of information about the true reflection of how the bladder is working on a day-to-day basis, which even the urodynamics would not give you. So that is why it is put up here. Urine routine. Yeah, go on, Dr. Amita.
Dr. Meera, yeah, the last slide, I just want to mention that we have issued guidelines. GIPS have issued guidelines, and the first line in investigation, she has included all, apart from uroflowmetry, which we only do once we suspect a kind of voiding dysfunction or any other problem. Otherwise, the urine routine culture, bladder diary, and ultrasound, because Dr. Usta rightly said that it's freely available in India. So we have included these kinds
absolutely,
of
absolutely
first line investigation in our guideline of India.
Yeah, that's right. So urine routine and culture were negative. So this rules out a recurrent UTI. So there's no point doing empirical treatment. This is the frequency volume chart. As you can see, it is definitely way above normal. Up to 7 to 8 voids during the day, and one maximum 2 for anybody aged above 70. Not definitely for a 38-year-old. The nighttime frequency is well above average. So it is definitely high frequency, both nocturia and diurnal variation. Uroflowmetry, low volume on all attempts. So she's not able to hold on. That's what it's telling us. Bell-shaped curve with terminal straining. Post-void residue of 20 ml. This is what has been shown. Dr. Charu, is there anything you want to come to a conclusion that we might be dealing with such a situation? What would you do at this instance?
Now we have to confirm our diagnosis, since we are going along the line of thinking of an interstitial cystitis type of picture. So we would, we have to prefer this cystoscopy to try and pick it up. Other than that, the investigations, I think, are just complete.
Okay. Dr. Vrinda, you have any other notion about proceeding with the cystoscopy, or we can go on an empirical management of this problem? Because she's obviously troubled. What are we going to do now?
Since there is no infection apparently here, it would be better to go for cystoscopy and make a definitive diagnosis of interstitial cystitis if it is.
Okay.
And
I'm coming back to Dr. Ranjana. Do you think cystoscopy is a diagnostic modality in this case or something else? Would you
So
place it at
again,
this stage? What should we do?
so again, as Amita said, we have GIBS guidelines.
Yes.
And we have also now a paper is coming when we should do cystoscopy and all that, right?
Yeah.
So, but if a patient comes to you with this history and these investigations for the first time in your OPD, you would start some medical treatment first, okay? Yeah. And see the effect. So what medical treatment? Now, this is the question, right? So can I just, I'm sorry, can I go back to the pain, type of pain you said in the first? Yeah. So all this, okay, right. So she has.
कहाँ चढ़ रहा है देखो कहाँ चढ़
Okay, so she has got vulvodynia, vestibulitis and all that, right? So we can start with some painkiller, and we can also give her amitriptyline and see how she she responds to it, and give her, like, from low dose, as Navita said, from low dose to increasing the dose. You can go up to 75 milligram, but you may not go up to that level. See how, and you can also give her some antimuscarinic along with it, and see how she responds to it. First, I would do that, and then if she does, yes, Amita.
Sorry, ma'am, I'm just interrupting. Like you mentioned about antimuscarinic. So for the uroflowmetry, so very rightly it is said that it is bell-shaped. So usually if a patient is of overactive bladder, you will see a different kind of pattern. There would be a sharp rise.
Sharp rise.
That's the difference. I think if somebody has done uroflowmetry, it is to rule out overactive bladder. So yes, low volume voids are there, but you have to see very carefully. And you have rightly said, yes, cystoscopy is an option to know more about the disease, what is whether ulcers are present or not. But if you are relieving pain and by that her flow is improving, probably indirectly it is confirming the diagnosis.
Yeah.
That is the first thing we should do, that stress management, pain management, nothing harm in doing that.
Anything if you want to do invasive, before that, it's always medical treatment.
Yes.
Just remember that.
There are some indication for a straightforward cystoscopy.
Yeah.
If
Hematuria and other stuff like that.
Blood is there. So please, then probably these patients need a urological consultation as well, because you have to rule out what is the cause of blood. Even in interstitial cystitis, when ulcers are present, blood could be there. But these patients require immediate cystoscopy if hematuria is there. So that is very, very important. Even if the culture is negative, even if the culture is positive, then probably blood can come because of the infection. But once the culture is negative and urine routine is showing blood, these patients should have cystoscopy. And another problem is that if a patient is having history of smoking, then also if there is a kind of picture, then probably these are the patients who are high risk, and cystoscopy. And what is the role of cystoscopy in these patients? To rule out other problems. The definition of interstitial...
Not to diagnose bladder pain syndrome.
These are diagnosis of exclusion. So you have to exclude all common factors by history examination and urinalysis. The most common differential diagnosis is UTI. So you can, but if there is a suspicion of other disorders, then you can always investigate patient further.
The main two things are GUTB and carcinoma in situ, as you rightly put, Dr. Amita. So these are the two things which we need to rule out before we term somebody as bladder pain syndrome, especially in the presence of hematuria. Yes, ma'am. Sorry.
And your painkillers, what I mentioned, they are not going to help you if somebody has got already carcinoma in situ and tuberculosis.
Absolutely.
It's worth trying, and things are not going to, you're not going to spoil her.
Actually, ma'am, the carcinoma, this is the pathognomic of cancer, that it is painless hematuria.
Yeah.
So sometimes things can be combined itself. So blood is not a good thing. So if blood is there, cystoscopy should be advised.
Should be. Then it's a different
take home message.
So we have to, these are the multi-pronged therapy which we do in a step ladder fashion. The first 4 or 5 come together. It's not a single method. We put everything together. The patient food management, we have to advise them to avoid certain food, and elimination diet. We have now handbooks from the GIPS Society, which has come out as treatment with the dietary modification as well. They need to understand which to avoid, what they can incorporate in their diet, and no single effective therapy. Have set realistic goals. Accept the fact there might be flares and relapses. So to understand, when I explain, I tell them it's something like asthma or arthritis. If ice cream is going to bring on an attack, you avoid ice cream. Similar to that. So they should understand what they're going to avoid and what they're going to take on a regular basis. Of course, pharmacotherapy, making them comfortable and also preventing the disease. And then comes our cystoscopic procedures. So these are the first line management and the coping strategies and dietary modification. We have then moved on to the pharmacotherapy as well. I would like Dr. Amita ji to talk about intravesical at this forum.
Okay, just shortly, because I think we are running short of time.
Yes,
so
which is why I quickly complete that.
There are some questions as well. You have to address those questions from attendees as well.
Yeah.
So for the thing is that once oral treatment is not giving the complete effect, and also if the side effects profile is there and patients are not able to tolerate, then there is a role of intravesical treatment, because you are giving the medication directly into the bladder. So the dose would be higher, and also there would be least systemic absorption. So the side effects would be much less. So that is the actually theory behind the intravesical treatment. And usually we give those agents which repair the bladder wall gag layer, which is actually deficient in interstitial cystitis. And there could be a multiple of gag analog. Only recommended are, which were recommended by international guidelines, are heparin, DMSO, and I think for intravesical installation, lidocaine is also has been approved. So you can combine also. Like DMSO is not available in India, so what we are doing, that we are combining heparin with lidocaine, or my choice of medication is bupivacaine, and also you can combine some kind of steroid or something which can add in the relief in the symptoms. So there are some cocktail regime which are available. You can see in our, if you, Deepti can share the GIPS, that small notebook of all these things to you also. You can see all these kinds of regime as well.
So Meera, before installation, we could consider pentosan.
Yeah. Medical management.
Medical management. So pentosan can also be given with before.
So I think, Dr. Meera, for gynecologists who are not very well versed with the kind of installation, all these therapies, at least oral management should be the, you should, at least you can start the pentosan if you are sure about this diagnosis of bladder pain syndrome. And for the pentosan, what my take home message is that please, the dosing is very important. Don't allow your patient.
And how you take it.
Yeah, don't allow the patient to take it twice a day, because it's a thrice a day. It's a biomedicine. If they are not taking it rightly, it's not going to affect. And the effect of medication, it's very slow acting medication. The effect comes in 3 months time. So you have to tell patient, it is costly medication. Only prescribe the medication once you are confirmed of the diagnosis, and you have to tell patient for 3 months they have to take for relief, and after 3 months, 3 months more for maintenance.
And before food and all those instructions, they should be given.
And it should not be taken with meals, either 1 hour before or 2 hours after meals. You have to very clearly write in your prescription. If these things are not followed, probably they will waste their money and time.
They will say it doesn't work.
Yeah. So that is the thing. It's a medication. If it works, it gives a very good relief to the patient. So you can combine with a fast-acting drug with that of pentosan as well. Like Dr. Navita told, some of the drugs for the neuropathic pain, amitriptyline or pregabalin, can be combined with pentosan to give immediate relief, because patient will not have immediate relief with this medication. Yes, it will heal the layer and will give a long-term relief.
And it's also should be stored in the door of the fridge. Otherwise, the bioefficacy also diminishes. So that's something it's important.
That is why biomedical medicine should not be exposed to the sunlight.
Yeah. So this is the take-home points here. Both interstitial cystitis and overactive bladder should be considered in the differential diagnosis of patients who present with this triad: pain, frequency, urgency. If there is nocturia, definitely think of interstitial cystitis more than overactive bladder. Should be considered in any patient who has got a refractory symptom of OAB, particularly after starting them on antimuscarinic therapy. Always consider IC, especially if there is food-related trigger or post-menstruation and sexual intercourse. And you do not need elaborate investigation. The basic stuff as already mentioned. And maybe if there is hematuria, go for cystoscopy as the diagnostic modality. Otherwise, symptomatology, your usual questionnaires, your frequency volume chart, your food diary will clinch the diagnosis in majority of the patient. Any patient with chronic pelvic pain, thorough patient history, determine whether cyclical or constant, what are the exacerbating factors, how does it affect the quality of life. And just for you to understand the type of pain, this is what the mnemonic has been given. So treat early to prevent transition. Once the central sensitization happens, it is difficult to treat these chronic pain syndromes. Hysterectomy is not a definitive therapy for all women with endometriosis or CPP. So if they fail your clinical trial of GnRH analogs, they should not be a candidate for hysterectomy because that is also not going to relieve the pain. Take a multi-system approach, combining cognitive behavior therapy, physical therapy, medical therapy, and interventional strategies, and reevaluate if you're not clinching the diagnosis. Choice of treatment also customized. One treatment does not fit all. Be less ashamed to involve your colleagues. Be more open about multimodality therapy. So I think that is the way it goes. Teamwork is the best, which is obvious from what we are having today as a panel. And thanks for all the brilliant inputs for managing these three cases. Thank you.
There is a question from an anonymous attendee. Very good question. How to differentiate between adhesions and endometriosis and neuropathic pain by history and pain characteristics? So somebody want to understand?
Take the question.
What's the question?
How to
differentiate between adhesions, endometriosis, and neuropathic
pain by history and pain characteristics?
Okay, can I try this?
Yes, ma'am.
Yeah.
Please.
Okay, so if you just go broadly, endometriosis pain we all are very familiar with. That with it may start before a period, it will get worse during a period. Sometimes people say with the onset of period it gets relieved. So this is unlikely to be endometriosis. What I'm saying, it's a typical case, right? So they can be atypical cases everywhere, but typically endometriosis pain will be related to, it will be cyclical and it will happen around the periods. So that's one thing, right? Now adhesion pain can be anytime. Sometimes they say when I have food, I feel pain. When I go to the toilet, so you don't know whether with the movement of the bowel or there is some stretching due to distension of any organ and adhesion, or adhesion pain can be there all the time, anytime. Neuropathic pain can be confused with adhesion pain because adhesion can also lead to neuropathic nerve entrapment because of fibrosis adhesion. So these two are very difficult to differentiate by pain and history. So by history and just pain history, right? So they should be treated actually as one because treatment is the same. Treatment is, we are not going to do adhesiolysis. That we know that if a patient has adhesions, we do adhesiolysis, we make recurrence of adhesions, right? So it's not a permanent cure. So treatment will be the same. Sorry.
initial treatment of all these things. For neuropathic pain, it's usually radiating. Once the nerves are involved, then the patient will typically give the history that
along that nerve distribution, along that.
radiating from.
But not necessarily, Amita. Lots of times, you know, it's in the vagina, suprapubic pain, in the fornices, everywhere. So you don't know where it is.
Patient is saying a kind of altered sensation and radiating pain, it's neuropathic.
Yeah.
You can differentiate.
So can I add to this?
Yeah, sure, Amita, you have to add.
Neuropathic pain in the patient will, if you ask the character of the pain, they'll always say it's like burning, it's pricking, there's a pressure, and take pins and needles. So this kind of, if they give a history or the character of the pain is this kind of pain, then you are dealing with neuropathic pain. It can be due to adhesions or isolated neuropathic pain. So if you have this kind of history, then you are dealing with neuropathic pain. And you can start the treatment.
Sometimes a typical presentation could be there where you cannot differentiate, but if these things are present, then you can surely say that nerves are involved.
Nerves are involved.
That's the take home. And I think we should wind up now.
It's a long session.
So I request Dr. Urmila, please invite our, the person who is going to deliver the vote of thanks.
Okay. Thank you for a very lively and vibrant session, although it has really crossed beyond. I mean, thank you for the patience of all the panelists and attendees.
Veera did a very good job.
Yes, I can see 60 attendees still are.
No. There were 95 about attendees.
100 also.
Yeah.
I would like to.
I invite Dr. Shashi. Yes, Shashi,
Yes.
now your turn to take over and wind up.
Now my turn comes. I don't want it to wind up, but I would of course like to say a vote of thanks to all of you for sparing and for a lovely session, and so much out of the I should say so many things we got to learn. We take it for granted, this urinary symptoms. Oh, that is honeymoon cystitis. That is something like that. We just try to got them off. But it really, as you said, it should not be made into a chronic thing. So we have to catch it in the beginning only. So I would like to thank FEPPA, the FEPPA, the female the Pelvic Bladder Syndrome Society, and of course our global society also, and this we say that
Swati Spentose.
The Swati Spentose, founder patrons, and GOGS of course is always there to help in all academic activities and everything. We are always you all are welcome to take us help. Our president Dr. Veera Lohia is always very cooperative, and of course Dr. Urmila is ever bright student right from childhood. I've seen her, and thank you so much Urmila for bringing under this roof all of them. Dr. Ajay Rane from all the way from Australia. I saw so many people logging in from Nepal, and I must thank the speakers. They were with the, Amita Jain. I must say it was really enlightening, and Dr. Vidya Bandukwala washed all our cobwebs of mind. And Navita Purohit, really, I'm very, very thankful to you. I must not forget my chairpersons, Dr. Amita, Dr. Kusum, and Dr. Roza Olyai. Roza being our society's oldest and brightest member and leading member. Kusum Singhal, also a brain think tank of our society. Then Dr. Yashodhara Gaur, she will go a long way. She's so visionary. And Dr. Neelam Rajput from Kamla Raja, our college. And Chairperson Dr. Anjali Jain, I have yet to see a surgeon as bright as her. And Dr. Sonal Kulshresht, another bright junior of mine, but ahead of me in so many things. And lastly,
Dr.
all
Vrinda.
our panelists, Dr. Ranjana Sharma, so happy to meet you. Yesterday was tremendous meeting. Now today I heard you. Dr. Meera Raghavan, Dr. Vrinda, our HOD, Dr. Charulata Mittal, Dr. Urmila as usual, and Dr. Navita Purohit. So I take your leave and I thank you all. And so
Thank you so
let's hope we meet again in future. So this is the virtual beginning inaugural function.
Yeah, this is
more and more things to come. Madam Veera, Dr. Veera Raghavan, your panel questions were too good. Please share and please share the recording also with us. Amita,
it'll be there with Dr.
this recording. So many people must have missed it.
I was babysitting Dr. Vidya's presentation. So last minute promotion from my side.
Yes. So everything.
You did a very good job, Meera.
You very well conducted.
Wonderful job.
Last minute
I know.
did the excellent job. And ma'am, it's the end of meeting, but not the end of our association.
Of course.
To be associated for all our upcoming meetings, because we have to do that last slide of Dr. Meera, teamwork. We need to actually spread awareness together so that we can actually deal with these disorders in a better way.
So we have to have these meetings more often.
Yeah.
Because 100 people logged in, that was not enough. So we have to have 100 every time.
Actually, we only see the vagina and vulva. We have a tubular vision, but we miss out the urethra and all those things. That is surgeon's domain.
Well, this what pelvis, ma'am. We have to deal with the pelvis. So it's why we have.
Dr. Amita,
We should have a wider vision.
one last word. There are
It
people
was so
off
nice.
the screen, off the screen, and it was the incessant work of Deepti and Cheshta, and who has made it
Oh,
so
yes,
smooth.
sure.
And I forgot to add one more thing. We have
Deepti
one
and
ICOG
Cheshta.
point for this.
Yes,
We have an
yes,
ICOG
yes.
point. So
Yes.
Thank you, everybody. Thank you. We'll meet again.
Thank you, Amita. Thank you, Veera. Thank you, everyone.
I will have to add one more point to all out there. It is not just a team. I have been associated with Gibbs. Gibbs is more like a family close to heart. And with Mr. and Mrs. Jajodia, Deepti, Cheshta, the entire team, we feel we are at home whenever we attend these conferences. And I'm sure everybody will feel the same. So please join the family. I do not want to belittle calling it the team. Thank you. Have a good day.
You've already joined your family.
And in 5 years, our family has become stronger. you know?
Absolutely.
Now this is an
Thank you
extended
so much.
family.
thank you, Deepti.
Yeah,
Congratulations.
Bye.
and
Bye.
Dr.
Bye. Thank you,
Amita,
everyone.
thank you so much for keeping the inaugural meeting here
Yes.
in the Gwalior. We feel so honored that you decide, Urmila, and you decided to keep it here.
Vishalji, do you want to say
Thank you.
something?
No, I am already overwhelmed and it was very interesting.
I think I spoke his mind.
Yes. and I assure you that we will do scientific progress in this platform as well. And you all will be proud of what we achieved from India. That's my commitment.
Of course.
Thank you.
All these obstacles.
You are such a driving force.
Yes, Dr. Navita Patel, Dr. Vindhya was not able to attend. After all these obstacles, Dr. Ajay Rane was not approachable. All these things, and I give this share to Deepti. She
And
was on
Cheshta.
tips.
Thank you, Deepti.
Yeah, that's very
Deepti Cheshta, you are wonderful.
wonderful.
Yeah,
Thank you, Cheshta.
Thank you, ma'am.
Thank you.
As always.
Thank
Thank
you,
you.
Doc.
Congratulations
Thank you.
to the team
Thank you.
behind this.
Hello.
Trust in us and confidence.
Okay.
See you
I'm,
then.
I'm motivated to do this meeting here now in Delhi.
Yes, ma'am. So now next we will approach you. Okay.
Congratulations, Gogs. Congratulations.
We are
Another
ending the
feather to our
meeting.
cap.
Oh,
Yes.
Take care.
Yes.
Bye.
Thank you, Roza.
Yeah. Thank
okay.
you.
Bye-bye, everyone. Thank you so much.